So we shall cover the lectures in 2 sessions of 3 each. After first 3 lectures by Dr. Bartak sir, Dr. Goyanka sir and Dr. Kanvinda sir, we will have a small program of inauguration and release of our quarterly magazine, Spandan. In second section of lectures, we shall have lectures by Dr. Sadhav sir, Dr. Tongaonkar sir and Dr. Singh sir. We have chairpersons for each lecture. After each lecture, the question answers will be taken. The questions will be put to the speaker by chairperson. The delegates online, they will put the questions in the chat box. With the time limit, we can take only few questions. So kindly note down the contact numbers of the speakers to solve your queries online or queries afterwards. Today's webinar is accredited with 1 MMC credit point and the technical support is provided by Digital platform. After academic event over, all the delegates who are registered for MMC credit hour, they will receive a feedback form on email. Once this feedback form is given, the certificate can be downloaded. Today we have Dr. Dilip Kamath sir, pattern IMA PCB as MMC observer. Welcome sir. I invite Dr. Sadhav sir, organizing chairman of today's webinar, for his welcome address. Sadhav sir, please.
Good morning. Good morning, everybody. It gives me an immense pleasure to welcome you all in this academic feast hematology update webinar jointly organized by IMA PCB and Aditya Birla Memorial Hospital. Life has changed since outbreak of corona pandemic. On academic front, also we are seeing new conditions or a variable presentation of known conditions. IMA PCB is a vibrant branch. We always want to excel in newer fields. Hematology is such a field, a vast field, and hence we have decided to have webinar on hematology update. I thank Dubey madam and her team for their wholehearted support. Today we have excellent speakers who are at topmost position of their field. Their presentation surely will help all of us to know more details of hematology. I welcome and thank all speakers also. Without wasting much time, we should start our amazing journey in hematology update. Thank you. Dr. Archana? Yes.
Thank you, sir. With the permission from the dais, we'll proceed for our academic session. Sir. So I welcome our chairpersons for the first session. Dr. Suhas Mate, sir. Welcome, sir. He is the immediate past president IMA PCB. And Dr. Shubhangi Kothari, madam, chairman IMA Women's Wing IMA PCB. And she is the leading anesthesia. Welcome, madam. Welcome, sir. I will invite our first speaker, Dr. Sandeep Bartak sir, and his topic is ABC of CBC. Sir is a consultant hematologist oncologist in Aditya Birla Memorial Hospital, Jupiter Hospital, Surya Mother and Child Care Wakad, and Bharati Vidyapeeth Medical College Pune. He has blood clinic and cure first lab. It is said that blood tests readily obtained from a routine complete blood count can aid in the early recognition of COVID in patients as well as provide prognostic information. Sir has more details about this. Over to you, Sandeep. Thank you, sir.
Presentation. हमको नहीं दूसरा Good morning, everyone. At the outset, let me thank the IMA team for organizing this update and inviting me here to speak on ABC of CBC. As we know that the CBC is the most common test that we order, let it be any specialty. And nowadays, it is the modern cell counters are easily available to everyone, and it gives lot of information actually. And today we'll try to see how we can interpret these reports, and I'm going to focus on helping getting these reports to evaluate anemia in children and adults. So let's begin. So CBC has many components. It is still unfortunate that sometimes I see reports where only hemoglobin, WBC, differential and platelets are reported. So ideally, you should demand all the indices and the information available in the CBC. So a complete hemogram should include hemoglobin, hematocrit, just I think I need to share the screen. You can see. No, share screen.
Share screen.
Hello.
Just click on share screen. खालती button है ना? There's a green button, sir, at the bottom.
Okay. Yeah. Sorry for the technical problems. So as I was saying, hemogram report should include at least hemoglobin, hematocrit or PCB, total RBC count, mean corpuscular volume, MCV, mean corpuscular hemoglobin, that is MCH, mean corpuscular hemoglobin concentration, that is MCHC, red cell distribution width, RDW, total WBC count and differential and platelet count. Okay, so again, out of this, I would say you should remember only a couple of parameters which are really important in assessing the anemia. So out of that, most important is mean corpuscular volume. Okay, so the normal range is 80 to 96 or 98, and we classify anemia depending on the MCV. So if MCV is less, it is microcytic. If MCV is high, that is macrocytic. And if it is between normal range, it is normocytic. Okay. So the next important parameter in the RBC indices is red cell distribution width. So what is RDW? So RDW is nothing but measure of red cell anisocytosis. That means variability in the red cell size. Okay, so the more the variability, the higher is the RDW. And the normal range, there you would see there are two different ways to calculate RDW. One is RDW-CV, which is commonly reported in the hemograms. So the normal range is 11.5 to 15. And sometimes some cell counters also give RDW-SD. So the normal range is 39 to 46. Okay. One should also remember that red cell indices are affected by many clinical conditions. For example, if patient is dehydrated, your hemoglobin will be little higher, your PC will be higher. If patients conditions like hyperglycemia, hyperlipidemia, hyperbilirubinemia, and red cell agglutination can affect these indices. For example, so if you have red cell agglutination in cases of cold AIHA, you will have spuriously high, very high MCV. So you should always interpret a hemogram in the clinical context. So just briefly about platelet indices. Again, these are reported in hemogram. So, and these are helpful in evaluation of thrombocytopenia and thrombocytosis. You need not remember all the things. Just two important indices. One is similar to MCV, you have MPV, that is mean platelet volume. The normal range is between 7.2 to 11.7, and platelet distribution width, as similar to RDW, you have PDW, again measuring the variation in the size and the shape of platelets. So normal range is between 9.6 to 16. Okay. And similar to retic count that we have in RBC, there is something called as immature platelet fraction. This is not available with all the cell counters. It is only available in certain cell counters like Sysmax, but it is a very important marker, and the normal range is between 1 to 7%. So it is really important in evaluation of thrombocytopenia. So if your IPF is high, that indicates your platelet production is normal or more, and that indicates it is platelet destruction. For example, in immune thrombocytopenia, you will have IPF which is high. But if thrombocytopenia is due to problem in the platelet production, for example, bone marrow failure or other like megaloblastic anemia or aplastic anemia, then your IPF will be normal or low. So these indices are really helpful in assessment of thrombocytopenia, thrombocytosis, and platelet recovery in dengue fever. So in dengue fever, we know that there is thrombocytopenia, and if you monitor IPF and your IPF is above 10%, that indicates imminent platelet recovery, and you need not give platelet transfusion in such patients. Okay, so another thing which you must have seen on the hemogram report are the histograms or graphs. I'm not going to go into details of this, just to tell you that there are platelet graphs, RBC graphs, and WBC graphs, which give a lot of information to us, pathologists and hematologists. Again, you need not know in details, but this is one of the important parameters in CBC. So similar to RBC histogram, you have WBC histograms, and by this we can measure whether there is neutropenia or lymphocytosis, or if there are presence of blast. So this is one of the important parameters. Now CBC also should include ideally reticulocyte count. So this is an investigation we often forget, but it is most useful in hematology, especially if you are dealing with case of anemia. So reticulocyte count, as we commonly reported it, is relative reticulocyte count, that is in percentage of all RBC. So normal range is between 0.8 to 1.5. And some machines also give directly absolute reticulocyte count, and the normal range is between 50,000 to 75,000. But we should also know we have to correct this reticulocyte count for anemia, okay, or packed cell volume. So, for example, if the patient has hemoglobin of 8, then you expect reticulocyte count to be higher because marrow is going to try to produce more reticulocytes. So we have to correct this reticulocyte count for PCV. The formula is relative retic count into PCV divided by 45. 45 is the normal packed cell volume. Again, further, we can also do reticulocyte production index, but that is mainly for pathologist and hematologist. Another very, very important part of evaluation of anemia and is peripheral blood smear. So without this, we cannot evaluate any case in hematology, and definitely not any anemia. So you have, although you all of you are not expected to know details of PBS, but at least you should ask for ask for PBS from pathologist. Okay, so coming to classification of anemia based on RBC kinetics and size, as I said previously, you have to look at MCV and retic count. So if MCV is low, it is microcytic, normocytic, and macrocytic anemia, and retic count either low or high. So what are the common causes of microcytic anemia? So the most common cause worldwide is iron deficiency anemia, then beta thalassemia trait or beta thalassemia major, and also alpha thalassemia. Other rarer causes, lead poisoning, sideroblastic anemia, anemia of chronic disease. So let's look at one first case. So 23-year-old female, she presents with fever, cough and cold, and on examination there is mild pallor, there is no organomegaly, and this is the hemogram. So hemogram shows anemia, that is HB of 9, MCV is low, 65, MCH is low, RDW, as you must remember, that with this is normal, 14. RBC count is 5.2, that is normal. WBC and platelets are normal. So here we are dealing with a microcytic anemia with normal RDW. So the most common cause, as I said, is iron deficiency anemia. But the most difficulty is sometimes to differentiate between iron deficiency and beta thalassemia trait or alpha thalassemia trait. So how do we differentiate? So MCV will be low in both the cases, MCH will be low in both the cases, but RBC count will be low in iron deficiency and high or normal in thalassemia trait. And RDW is high in iron deficiency and RDW is normal in thalassemia trait. So just one rule, if RDW is high, it usually indicates nutritional anemia. So if you remember the case, in our case, the RDW was normal and the RBC count was normal. So it was a beta thalassemia trait. Again, you should look at the smear. You should always confirm these findings by looking at the smear. So normal RBCs are, as you can see, they are oval shaped with a central pallor, which is usually 1/3 of the diameter of the RBC. As against in hypochromic or microcytic anemia, you will have smaller RBC size and the central pallor will be bigger. So that indicates hypochromia. So in thalassemia trait, as you can see, most of the RBCs are small, but they are of similar size. There is hardly any variation in the size, which means RDW is normal. And this is consistent with thalassemia trait. As against this is the picture in iron deficiency anemia. Here you can see most of the RBCs are hypochromic and microcytic, but there is a lot of variation in the size. Some are smaller, some are little bigger, some are pencil cells. So this is classical of iron deficiency anemia. In beta thalassemia major, you will have lot of targeted cells, very high anisocytosis, very high RDW, and sometimes presence of nucleated RBCs. So coming back to our first case, we suspected it was a thalassemia trait and went ahead with HB electrophoresis. And as you can see, the HbA2 was high, 4.9%, which confirms it was a case of beta thalassemia trait. Okay, so this beta thalassemia trait is confirmed by HB electrophoresis and iron deficiency. You can confirm the diagnosis by doing iron profile, that is serum iron. Total iron binding capacity will be high, serum iron will be low. But remember, sometimes patients, if they're already taken hematinics, your serum iron may not be low. Serum ferritin is very specific for iron deficiency. So serum ferritin, if it is low, it confirms iron deficiency. But again, you have to remember serum ferritin is also an acute phase reactant. So if the patient has any infection, fever, or other inflammation, your serum ferritin will be high. So it will not reflect the true iron status. So in those cases, sometimes we take help of further tests like soluble transferrin saturation. And if you are quite confident from history, examination, and your hemogram interpretation that this is iron deficiency, you need not confirm it by doing this test, and you can directly go ahead and treat the patient with oral iron and do a therapeutic trial. And after 1 month, you again check your hemogram. And if there is at least 1 gram rise in hemoglobin, your diagnosis of iron deficiency is confirmed. We'll move on to the next case. So this was an 8-year-old girl presented with pallor, weakness. There was no fever, no history of blood transfusion in the past. On examination, she was well, and there was pallor, no lymphadenopathy. Only spleen was little 2 centimeter palpable below the costal margin. And this is the hemogram. There is severe anemia, and MCV is very low, 62. RBC count is also low. MCH is low. RDW is high, and WBC and platelet count are normal. So as we have learned, normal low MCV and high RDW is in favor of iron deficiency. So this patient was treated with oral iron. However, after 1 month, the hemoglobin was almost the same, 6.9. There was no change. So what would you do now in such situation? So this is iron refractory anemia. First of all, you have to make sure that compliance is there. Many times, children or adults, they do not take adequate iron, and so the compliance is very important. Again, the next is whether the diagnosis of iron deficiency was right. So was it a trait, beta thalassemia or alpha thalassemia trait? So in those cases, you can confirm the diagnosis of iron deficiency by doing iron test and ferritin or HB electrophoresis. And once you have confirmed and still the patient has iron refractory anemia, you should also rule out ongoing blood loss. The most common site for blood loss in adults is GI tract. So you should evaluate accordingly, and sometimes you may have to go ahead and do upper and lower endoscopy. There can be absorption problems for iron, for example, celiac disease. So that needs to be ruled out in proper clinical context. In adults, chronic H. pylori infection also will lead to iron refractory anemia. Okay, and again, one of the important cause is chronic use of antacids, including pantoprazole, where your gastric pH is normal and your iron absorption is impaired. Okay, and there are sometimes rarer metabolic causes of iron absorption, which we will not go into. So coming back to the case, so we confirmed that it was iron deficiency by doing serum ferritin, which was low. And then we, of course, there was no obvious blood loss, and we worked up for celiac disease, and anti-TTG IgA was very high, and which per GI-scopy showed duodenal villus atrophy, which confirming the diagnosis of celiac disease. The patient was started on oral iron supplements and gluten-free diet. After 3 months, hemoglobin normalized. So let's see the next case. So 47-year-old male, he was again referred for anemia. No significant past history, no obvious blood loss, and on examination there was pallor. and no lymphadenopathy or hepatosplenomegaly. So HB was 5.4, MCV was 82, which is normal. RBC count is 3.8, which is low, and your RDW is just slightly above normal. WBC are 6,900 and platelets are 2,30,000. Now here we are dealing with severe anemia. So any anemia, especially in male, one should look for detailed workup. So normocytic anemia. So now we are dealing with normocytic anemia. So what do we do after, once we see the normocytic anemia? We should always ask for a reticulocyte count. So either it is low reticulocyte count or high reticulocyte count. So if it is normocytic anemia with low reticulocyte count, one has to remember that the problem is in the production. Okay, so there is problem is with the bone marrow. So decreased stimulation of the bone marrow. So anemia of chronic disease or chronic renal failure or other metabolic disorders, or sometimes there is pure red cell aplasia, or there is bone marrow infiltration by malignancy, either leukemia or other tumors, or sometimes intrinsic bone marrow disease like MDS or myelodysplasia. So the problem is in the production or in the bone marrow. So we, coming back to the case, the retic count was 1.1% for, so as you remember, 1.1% for hemoglobin of 5.4 is low. So corrected reticulocyte count will be very low. And if you look carefully in the previous slide, I have mentioned WBC of 6,900, which is normal, but look at the neutrophil, just 11%. So one should also look at the differential, and the absolute neutrophil count was 759, which is low. So there is definite problem with bone marrow. So we went ahead with the bone marrow examination, and this is what we see. There are blasts, and this was a case of acute myeloid leukemia. Okay, so the next case, 4-year-old boy, he presented with pallor, jaundice, dark colored urine, and there was history of fever also. Otherwise, previously he was healthy. And look at the, on examination, there was pallor and icterus, otherwise no lymphadenopathy or hepatosplenomegaly. So on examination, he had hemoglobin of 8.4, low, normocytic again, MCV is normal, and rest of the workup was negative. So let's look at the retic count. So retic count here was high. So normocytic anemia, high retic count, you should think of hemolytic anemia. So hemolytic anemia can be because of extravascular RBC hemolysis, and these are the causes, or it could be intravascular hemolysis because of various causes. So how do we know that it is hemolytic anemia? So you should do a retic count, which will be high. There will be polychromasia on the smear, and high indirect bilirubin, increased LDH, and low haptoglobin. So this will confirm there is hemolysis. And further, you have to find the cause of hemolysis. So coming back to our case, retic count was very high, and LDH was very high. G6PD was normal, and DCT was negative. However, when we looked at the smear, there were bite cells, so which was highly suggestive of G6PD deficiency. So you would say why the G6PD was normal? Because when you have a lot of hemolysis and young RBCs, you will have falsely normal G6PD. So one should repeat after 3 months, once the episode of hemolysis is over and once the blood transfusion has been done. So we confirmed after 3 months G6PD was low. So this is polychromasia I was talking about, bluish discoloration. And in hemolysis, blood smear is very important. You can get diagnosis or clue to a diagnosis. So you can see spirocyte in hereditary spirocytosis or autoimmune hemolytic anemia, sickle cells in sickle cell disease, elliptocytosis. You can see falciparum malaria, and that can also lead to hemolytic anemia. And you can confirm the diagnosis by doing specialized test. So just the last case. Now we'll look at the macrocytic. So we have looked at microcytic, normocytic, now macrocytic. So 14-year-old boy presented with tiredness and decreased appetite and pallor. There was no hepatosplenomegaly. And you have here hemoglobin 6.1 and MCV 110. So definitely it is macrocytic. And look at the RDW, which is also high. So and WBC are low, 2000, it's actually pancytopenia. Okay. So if MCV high, again the same thing. Look at the reticulocyte count. If it is low retic or high retic, if it is high retic, it is hemolytic anemia. And if it is low retic, then the most common cause is megaloblastic anemia, which could be because of B12 deficiency or folate deficiency. But there are other non-megaloblastic causes of macrocytosis, including liver disease, hypothyroidism, drug-induced or MDS. So you should keep this in mind. And coming back to our patient, he had macroovalocytosis and hypersegmented neutrophils, suggesting a diagnosis of megaloblastic anemia. And indeed, the patient had low B12 levels, and it was treated with B12 injections. So to summarize, you have to classify anemia based on MCV, RDW, and the PBS examination is really important. Without that, you cannot diagnose a case of anemia. And of course, in refractory cases, one can take experts' help. Thank you. Yeah. Mike.
The picture in viral fever.
Okay, so I think we have further talks later on about COVID. But any viral fever, again, there is nothing extremely specific, but generally in viral fever, you tend to have sometimes leukopenia. For example, in dengue, you may have leukopenia or thrombocytopenia, which is very characteristic of dengue and some other viral infections. Some viruses cause lymphocytosis. For example, EBV will cause lymphocytosis. But some viruses, we see lymphopenia. For example, in COVID, it's actually lymphopenia. So in fact, neutrophil lymphocyte ratio is important. So again, this is not very specific, except, I would say that some viruses cause lymphocytosis and atypical lymphocytes. So for example, if you see EBV infection, you will have something called as atypical or reactive lymphocytes. So those things are there, but there's no one particular thing that confirms that this is a viral infection. Yeah.
He wants to know the effect of blood transfusion on iron studies.
Iron studies. Okay, so so if you have given blood transfusion and if you immediately do serum iron, your serum iron may be falsely normal. Okay, so because whatever iron, serum iron, which reflects iron absorbed in last 24 to 48 hours, and what you have received from intravenously or by the way of blood transfusion. So you will not be able to rely on serum iron, and hence TIBC if you have given blood transfusion immediately, for example, in 1 or 2 days before. But ferritin will not be affected if you don't have other signs of inflammation or other infection. So ferritin will not be affected, but serum iron and TIBC can be affected by blood transfusion immediately. After 7 days or so, even that will not be affected.
One more question by Dr. Monson. What is sideroblastic?
What is?
Sideroblastic.
So sideroblastic anemia. So sideroblastic anemia, where we see in bone marrow something called as sideroblast. So those erythroid precursors, they have a ring of iron ring. Okay, so they have the mitochondria around the nucleus, which will be stained by iron. So these are sideroblasts that we see in the bone marrow. Now the common causes of sideroblastic anemia are either acquired or congenital. So acquired causes is usually alcohol is the most common cause, or certain drugs like INH. So isoniazid will cause sideroblastic anemia. And the congenital causes are caused by enzyme deficiencies like ALA enzyme deficiency can cause sideroblastic anemia. It usually presents with microcytic anemia.
A question from Dr. Vijay sir. What are the findings with
MDS.
from what anemia
Okay.
and viral?
So in MDS, okay, on peripheral, on hemogram, usually what we see is anemia and macrocytosis. Okay, most of the MDS will have macrocytosis. But your WBC and platelet also may be affected in MDS. So either you can have isolated anemia or pancytopenia, and your RDW will be usually normal. Okay. There are certain MDS, for example, 5q minus, where you will have thrombocytosis along with anemia. So you will have macrocytic anemia and thrombocytosis. Okay, but generally the diagnosis is done by examination of a bone marrow. So where you will see dysplasia. Thank you.
Thank you, sir, for your excellent lecture. Sir, I request Dr. Suhas Marty, sir. I request Dr. Suhas Marty, sir, to felicitate sir with IMA Uparane, Diary and Spandan. She will come.
hemophilia transmits via X-linked recessive inheritance. So the mainly affected people are males only. In rare cases, females can be affected, but it's a very rare. So let's have a scenario. In this scenario, mother is a carrier of hemophilia gene and father is normal. So the hemophilia travels via X-linked recessive inheritance. So 50% of the sons will have hemophilia and 50% of the daughters will be carrier in this scenario. And in the second scenario, in which father is having hemophilia and mother is normal, so father will transmit the hemophilia to the 100% of daughters, but they are carriers. They are not manifesting the disease, and 0% of the sons will be affected by the hemophilia. So to summarize, hemophilia is transmitted from mother to this 50% of the sons, and we'll have a family history of hemophilia in the maternal cousins, the maternal uncle. So to classify, coming to the classification based on the severity, the factor level percentage, normal factor percentage in our body is 50 to 150%. Based on the factor 8 level, we can classify the severity of the hemophilia. The mild hemophilias are in which factor level is 6 to 40%. They will not manifest spontaneously any bleeding symptoms. They will have bleeding after major trauma or surgery. The moderate hemophilias are those in which factor 8 percentage is 2 to 5%. They will have bleeding symptoms after minor trauma. And the severe ones are in which factor 8 percentage is less than 1%. They will have spontaneous bleeding as well as after trauma. So how these patients will start having bleeding manifestations? In severe disease, means patients with factor 8 percentage less than 1%, at the age of around 6 to 12 months, when the child starts crawling, when he is mobile, then due to the mobility, he will have easy bruising, soft tissue swelling or joint swelling. This is seen in the severe patients. In mild cases will remain silent till later in the life, but they will manifest during stresses like surgery. So what are the common sites of bleeding we in our daily practice see many bleeding symptoms, like patients come to us with epistaxis, oral bleeding, hematuria, skin bleeding. But characteristic bleeding patterns in hemophilia are they will have joint bleeding. We call it as a hemarthrosis. The second common bleeding symptom in hemophilia are muscle or soft tissue bleeding. Other rarely bleeding symptoms can be seen, but these are mouth bleeding, gum bleeding, or nose bleeding. And hematuria can also be seen. But the more concerned life-threatening bleeding symptoms in hemophilia patients are central nervous system bleeding, which is the leading cause of death in hemophilia patients. The other common life-threatening bleedings are gastrointestinal bleeding, neck and throat bleeding. Due to the if there is any bleeding or bleeding in the neck region, it can compromise on the vital structures in the neck after severe trauma in hemophilia patients. So coming to the specific bleeding symptoms in hemophilia patients, the most common and characteristic bleeding symptom in hemophilia patients is hemophilic arthropathy. The presentation, it can present in 3 different ways. It can be a acute bleeding, sudden recent onset bleeding, can be subacute or chronic synovitis, and it can be chronic hemophilic arthropathy due to repeated bleeding in the same joint. We call it as a target joint if there is a repeated bleeding in the same joint. You can see in the picturization swollen joint. So this is a characteristic bleeding in hemophilia patient, which is the most common, most painful, most physically, economically, and psychologically debilitating manifestation seen in almost more than 90% of the hemophilia patient. As you see in this picture, the left elbow of the patient is swollen, swelling is seen. On examination, he will be having the restriction of movements. There will be tenderness, and you can see the skin is shining. So this is a typical acute hemophilic bleed in the joint. If there is a repeated bleeding in the same joint due to the vicious cycle of synovial inflammation and bleeding, it can lead to the chronic hemophilic arthropathy. You can see in these pictures, due to the repeated bleeding in the knee joints, the joints will be deformed and swollen. The next common bleeding manifestation in hemophilia is muscle bleed. The most commonly involved muscles are calf muscles, buttock, and forearm muscles. But the important to notice and problematic muscle bleed in the hemophilia patient is this iliopsoas hematoma. It's the retroperitoneal in location. It is problematic because it can lead to the compartment syndrome due to the compression on the blood vessels and nerves. You can see in this picture it's showing the psoas hematoma. The next common bleeding manifestation, which is rare bleeding manifestation, but is the leading cause of death in hemophilia patient. It can be spontaneous or following trauma. The common locations for intracerebral, intracranial bleeding in hemophilia patients are subdural, epidural, or intracerebral. So in any diagnosed patients of hemophilia, if they present in our OPD with sudden onset severe headache, vomiting, so always suspect IC bleed, intracerebral bleed in this patient. So at the first suspicion, we have to treat this patient before diagnostic workup. We should not waste time in doing CT or MRI because this can lead to the progression of bleed in the central nervous system, which can be life-threatening. So at first suspicion, we have to first treat with the 100% factor correction in these patients. Then we can do the further diagnostic workup to confirm the diagnosis. And lumbar, and if we are suspecting any CNS pathology in hemophilia patients, lumbar puncture we should not do, but if it is absolutely needed, we have to raise the factor level in the blood by giving factor concentrates, then we can do the lumbar puncture. So other rare bleeding symptoms in hemophilia are mucocutaneous bleeding. These are rare, but this can be seen. Typically, a patient due to repeated joint bleeding, they will be taking in the rural setting. Many patients are undiagnosed due to the repeated joint bleeding. They will be taking NSAIDs like diclofenac, indomethacin, ketorolac. But as we know, these drugs are having the common side effect of peptic ulceration. So in the setting of hemophilia with chronic use of NSAIDs, this can lead to gastrointestinal bleeding and it can be a life-threatening. So other bleeding, mucocutaneous bleeding in hemophilia patients are epistaxis, oral bleeding, tongue bleeding after bite, and hematuria. So coming to the diagnosis, when to suspect hemophilia, we should suspect hemophilia when any patient is having repeated spontaneous bleeding or bleeding following trauma which is out of proportion to the injury. Normally, after injury, there is bleeding, but after some time it stops. But if the bleeding is out of proportion to the normal time, and if there is repeated bleeding symptoms, and in the setting of positive family history, we should suspect hemophilia. The positive family history we can get, as I told, it transmits from the mother to their 50% of the sons. We can get the positive family history in the maternal side. The maternal uncle, like we said, mama or Maushiche Muller, these people, we can ask for them. Specifically, we can ask them the sister, mother, sister, and uncle. So how to proceed for the investigation wise? As in every bleeding patient, we first do CBC and we look for the specifically platelet count because platelets are more concerned for the coagulation. So platelets are normal in hemophilia patients. And then we further advise for the PT coagulation profile, which includes prothrombin time, APTT, and thrombin time. So prothrombin time will be normal because hemophilia is due to the deficiency of factor 8 and factor 9, which are the components of intrinsic pathway. So intrinsic, due to the derangement in intrinsic pathway, it leads to the derangement of APTT only. Extrinsic pathway will cause derangement of PT and common pathway will cause derangement of both PT and APTT. So specifically in hemophilia patients, PT will be normal, APTT will be prolonged, and once if in the clinical setting of bleeding manifestation with APTT prolongation, we do mixing studies. We mix patient's plasma with the normal plasma. If the APTT got corrected, then we can justify that it is due to the factor deficiency. So in the setting of bleeding symptoms, APTT prolonged and mixing studies gets corrected, we can say it's due to the hemophilia. So we can confirm by doing factor assay to measure the levels of factor 8 and factor 9, and we can grade them according to the severity, according to the levels of factor VIII. So EPTD will be prolonged in the hemophilia patients, and factor assay will reveal reduced factor levels. Now coming to the treatment part in the hemophilia patients, there should be a comprehensive care in the hemophilia, because hemophilia will not affect only the patient, it affects whole family, because it will be having physical, emotional, financial and psychological burden on all the family members. So it should be a combined management. It has a comprehensive care. It is a multidisciplinary approach. Patient should be managed by the hematologist, pain management specialist, the nurse, which I will explain in the further slides, that prophylaxis, the family and friends, dentist, all these orthopedists, then psychologists, pharmacists. So hemophilia is having the comprehensive multidisciplinary management. Coming to the specific treatment, accurate diagnosis is very important in hemophilia patients, then a specific treatment, and there are some general measures. As I said, the hemophilic joint bleeding is typical in the hemophilia patients. So these are the general measures. It's a mnemonic for it is price. So first we have to protect the joint, then rest of the joint, ice application, compression, and erection. At any new joint bleeding, this should be the first general measures. Start from the home to the hospital. So what other general principles we should follow in the hemophilia patients? There are some do's and don'ts. So some things that we should avoid in patients: we should avoid intramuscular injections, because these injections can lead to intramuscular hematoma. A child with hemophilia should avoid all contact sports, which are high impact sports like cricket, hockey, football. And this patient should avoid aspirin and other NSAIDs, diclofenac, indomethacin, ketorolac. All the arterial puncture should be avoided in these patients. Difficult phlebotomy should be avoided. And the trauma, lifestyle should be adjusted by the general measures. So what are the to do things, do's, what are the do's in the hemophilia patients? At the site of bleeding, first we should ice application. Early factor correction is very important. At the first sign of bleeding, factor correction is very important, because it will correct the bleeding manifestation in the joint, and it will reverse the swelling. All procedures, like all surgical procedures, can be done in the hemophilia patient, but they should be done after the consultation with hematologist and after appropriate factor correction. So these are some physical activities. Child should avoid all the contact sports which will having high impact on their joints and their mobility. The child should be encouraged to take swimming, cycling, badminton, and table tennis. Now about the immunization, the child with hemophilia can receive all the immunization, but it should be given subcutaneously with the small bore needle, 25 gauge needle or 26 gauge needle, and firm pressure should be applied for at least 10 minutes after vaccination. And there is no need of factor correction before giving vaccination. This is a pain management in hemophilia. Which drugs can be given in hemophilia patients? These are the drugs which are safe in hemophilia: paracetamol, codeine, tramadol, etoricoxib are safe. So definitive treatment in hemophilia patients are factor correction. So factor correction is via two ways. It can be episodic after bleeding symptom, that is on-demand therapy, or it can be prophylactic. So what are the clotting factor concentrates? There are two different types of clotting factor concentrates. One are plasma derived. They are low, intermediate, and high purity. And the recent one are the recombinant clotting factor concentrates. There are various generation. So this is a tabulation which is showing in different types of bleeding what is the level of factor correction we should give in these patients. So this is a dose of hemophilia. This is dose of clotting factor concentrate in hemophilia A patients. In hemophilia A patients, 1 unit of factor correction raises the factor VIII level by 2%, because of there is a volume of distribution is double. So we can calculate by this formula the desired level minus patient's level into weight divided by 2, and the half-life of factor 8 concentrate is 12 hours. And in fact, in hemophilia B, we need not have to divide by factor by 2. We calculate by desired level minus patient level into weight. And the half-life of hemophilic factor 9 concentrates is 12 to 24 hours.
Doctor,
So this is a different formulation table available in our country. These are the factor 8 concentrates. These are factor 9 concentrates. The efficacy is more than 90%. These are the chronic complications of hemophilia, chronic hemophilic arthropathy, fracture, pseudotumor, and transfusion transmitted diseases. This is a very important concept in hemophilia patient. The prophylaxis we have. This is treatment by intravenous injection of factor concentrate in anticipation of or in order to prevent bleeding. The concept is we have to maintain the factor 8 levels more than 1%. This is a different types of prophylaxis: primary prophylaxis, secondary prophylaxis, and tertiary prophylaxis. What are the benefits of prophylaxis? It reduces the musculoskeletal pain. There is less need of orthopedic surgery in further life. Reduced hospitalization rates. Length of hospital stays decreased. Improved school and work attendance. Better academic achievement. And this is a recent advance like imicizumab is a bispecific antibody which can be used as a prophylaxis in hemophilia patient with inhibitor or without inhibitor. So what is so coming to the take-home message? There is a low level of awareness in our country because we have, and also there is lack of diagnostic facilities and treatment facilities. So accurate diagnosis is very important, and education of patient and relatives and their counseling, prompt replacement therapy with the required factor, early physical therapy, and prophylactic therapy for all, home therapy where possible is the mainstay of hemophilia management. Thank you.
Thank you, Dr. Goenka. There are 2 questions for you. Please explain antenatal counseling in hemophilia patients by Dr. Archana.
Okay. Antenatal counseling, if patient like couple is having a previous child with hemophilia or there is family history of hemophilia in the child, we can do antenatal counseling. We can tell them what are the possibilities of their child having hemophilia. First, there is carrier detection in the mother. If mother is a carrier, then there are 50% chances of their sons getting hemophilia. So antenatal counseling, we counsel them for the various methods of antenatal diagnosis via amniocentesis, chorionic villus biopsy, photosynthesis. These are at various types of pregnancy. Earliest is the amniocentesis. We take the cells, fetal cells, and we can see for the mutation. DNA analysis, we can see the specific DNA mutations which are specific for the factor 8 and factor 9, and we can come to know that whether the child is affected or not. So we counsel the parents about the possibilities, and we can move on. What are the different methods of doing antenatal diagnosis? What are the complications and what are the possibilities?
Thank you.
Thank you, Dr. Suraj. Sir.
Sir, one more question. Time is there? Yeah. What are the pre-operative workup for patient undergoing surgery for the elective surgery?
In hemophilia patients.
Yes.
Yeah. There is one concept in hemophilia, it's inhibitor development. Inhibitor is an allo antibodies against the factor 8. In a patient with hemophilia, if he is inhibitor positive, the factor 8 concentrate will not work in these patients. So any patient going for surgery, elective surgery, we have to look for the inhibitor in these patients, and we have to look for whether it is a surgery under local anesthesia or general anesthesia. Depending on the risk in the surgery, we have to decide the requirement of factor concentrates. Say, for example, in patients requiring surgery under general anesthesia, so we have to plan before the surgery. There is 100% correction prior to the surgery, and after that we can carry out the surgery, and we give like 50% correction after 12 hours, day 2, day 3, and we see the recovery of factor 8 in this patient. So it is a multidisciplinary, the plan is decided before surgery, but the important thing is we have to look for inhibitor in this patient, because if inhibitor is positive, then factor 8 will not work in these patients.
Thank you, doctor.
Thank you, Suraj sir, for such a elaborative lecture. Can we have a felicitation of sir? I request Kothari madam to felicitate Dr. Suraj Goenka sir. We have Dr. Ravindra Kute sir, Vice President, IMA Maharashtra State, as a guest of honor today in the auditorium. We welcome you, sir. Moving on to next lecture. The third lecture is by Dr. Shailesh Kanvinde sir. Sir is a consultant pediatric hematologist and oncologist, Dinanath Mangeshkar Hospital, Pune. Sir has done his MD from BJMC Pune in 1995. Sir is trained at Tata Memorial Hospital, Mumbai in pediatric oncology, hematology, and bone marrow transplantations. बचपन नादान था पर बड़ा शानदार था यार, असे आपण म्हणतो. सर काय म्हणतात ते बघूया. ओव्हर टू यू शैलेश सर.
Yeah.
Good morning, everybody. And at the outset, let me thank IMA PCB for inviting me to give this talk. It's indeed a great honor for me. I'm going to discuss hematological manifestations of infections in children. Now, why is this an important topic? Number one, the spectrum of problems which children can have as a result of infection, the spectrum of hematological abnormalities varies from cytopenias or abnormalities from platelets, WBCs, anemias, right up to lymphadenopathy, thrombosis and coagulation disturbances, and even lymphomas and other malignancies. In many of these situations, the hematological manifestations may give some idea as to what the underlying infection would be. Second, many times these abnormalities are not very serious in themselves, but cause a lot of anxiety in the patient as well as in the caregiver also. And of course, some of these abnormalities can be used for monitoring response to therapy and assessing whether the patient is responding or not. Some of these abnormalities, especially platelet abnormalities, would sometimes require specific treatment. So during the course of this talk, we'll try to cover some of these aspects. We'll be using certain case scenarios. So this is a 3-year-old child has fever for 4 days. This is an upper respiratory tract infection, otherwise is clinically stable. And just look at the CBC here. Rest is okay, but the platelets are low. Now this is a common phenomena. Thrombocytopenia is a common manifestation of various infections in children, predominantly viral, but rickettsial infections also are associated significantly with thrombocytopenia. Malaria is a factor. Congenital infections are also responsible for thrombocytopenia in in neonates and early infancy. Bacterial infections per se are rare as a cause of thrombocytopenia, but serious infections, gram-negative bacilli, may cause thrombocytopenia. So thrombocytopenia associated with infections is basically a common phenomenon, but it's usually mild. It's about, most patients usually have a platelet count more than 75,000 to a lakh. And severe thrombocytopenia is rare, except in patients with dengue or with rickets cell infections. So in most situations, no specific intervention would be required, even though the platelet count, a close watch on the platelet count may be indicated, but otherwise no specific intervention is necessary. One should remember to avoid steroids. They usually don't help, and they may cause problems of their own. NSAIDs also should be avoided because they do affect the platelet function, and a patient with thrombocytopenia would predispose to bleeding. It is important to document. Most of these thrombocytopenias would resolve within a week or so. Most of these thrombocytopenias would resolve in a week or so, and it is important to document recovery so as not to miss an underlying hematological condition. Because very often the patients may have unrelated thrombocytopenia, but we would assume it to be because of infections. And in that case, it is better that we always document the recovery. Thrombocytosis is probably a more common factor than thrombocytopenia in pediatrics. It is also an important cause for anxiety in the patients as well as the doctors. Iron deficiency anemia is the commonest cause of thrombocytosis in children, followed by infections. Generally, the platelet count remains around 6 to 8 lakhs, rarely going about 10 lakhs. And in children, no specific intervention for thrombocytosis is necessary because it doesn't lead to any serious complication. So you can just watch it, treat the iron deficiency which is present, and once the infection resolves, the thrombocytosis will also resolve. Coming to WBCs, now one look at the various WBC subtypes and their role in combating infection. Neutrophils predominantly target bacteria and fungi. Lymphocytes are responsible for protection against viral and protozoal infections, and eosinophils help in protecting or treating parasitic infections. Now, in bacterial or fungal infections, it is like we would expect a neutrophilic response. In viral infections, we would expect a lymphocytic response. On the contrary, if the neutrophils are low, the patient would be predisposed for bacterial or fungal pathogens. And if lymphocytes are low, the patient would be predisposed for viral and protozoal pathogens. So it is knowing what the abnormality is, one can get some idea as to what the likely underlying infection would be. I don't need to talk too much about neutrophilic leukocytosis. Everybody is aware. Infections are the commonest cause. The degree of leukocytosis depends on the type and severity of infection, where bacterial infections tend to have a higher neutrophil count than non-bacterial infections. In some situations, the count can be very high and give rise to what is called as a leukemoid reaction. With left shift, that means presence of immature myeloid precursors in the blood. Not so much of a problem in children, but in adults, this needs to be distinguished from other myeloproliferative conditions. In addition to number, even toxic changes like toxic granules may be noticed in the neutrophils. But it should also be stressed that neutrophilic leukocytosis does not necessarily equate with infection. And there are a lot of other conditions which can produce a similar picture. And clinical context has to be taken into consideration in interpreting the CBC. In children, various infections would tend to produce lymphocytosis rather than neutrophilic predominance. Viral infections being the predominant responsible factor. The common pediatric illnesses, the upper respiratory tract infections, the common viral infections which most children suffer from, will be associated with some degree of lymphocytosis. Significant lymphocytosis may be seen in EBV infections in the form of infectious mononucleosis, where the patient may have sore throat, lymphadenopathy, fever, splenomegaly, and lymphocytosis. A similar picture can also be seen in CMV, HIV, and other organisms. Pertussis is known to produce a significant lymphocytosis, but we don't see pertussis nowadays that often because of the vaccination. But occasionally we do see a child who has not received the full dose of vaccination. And in such situations, he's a person with a poor vaccination history with lymphocytosis, one should suspect the possibility of pertussis. Lymphocytosis, some of the lymphocytes may be atypical, and in this situation, a suspicion of an acute lymphoid leukemia would also be there. And most often such patients get referred to us to rule out leukemia. The second case scenario that we'll see, this is an 8-month-old child who has fever, again for 4 to 5 days, and has now come with breathlessness. And I would like you to focus on the WBC count. And you can see here that what do you think is this abnormality? There is a predominance of neutrophils. So is this neutrophilia? If you look at the absolute counts, what you see is there is leukopenia, and the neutrophil, so-called neutrophil predominance that you are seeing is actually because of lower lymphocytes. So this is actually a lymphopenia. So this is another message that I would like to say, is that always look at the absolute counts in interpreting whether it is neutrophilia or lymphocytosis or so on. Now, in this case, this is lymphopenia. And we've seen previously that lymphocytes are responsible for protection against viruses or protozoal infections. In addition, lymphopenia is a known lymphopenia occurs very often because of various viral infections. Currently, the COVID pandemic is described to be associated with lymphopenia, which is supposed to be a marker of severity of the disease. However, lymphopenia is again not specific for COVID. It is common in a variety of viral pathogens and other disorders. So on one hand, the lymphopenia may be due to the infection. On the other hand, the lymphopenia may be associated with an immunodeficiency disorder and will predispose to infection. So in this situation, knowing that the child is lymphopenic, we can have some idea as to what the particular infection in this case is likely to be. You can see the X-ray of this child showing bilateral haziness. This could be possibly a pneumocystis infection or one of the viral infections. And instead of treating this child with antibacterial agents and waiting for response, I think a prompt search for a particular viral pathogen is necessary, as well as in this situation, it is necessary to rule out or confirm an immunodeficiency. So the clue in this febrile patient with the lymphopenia is a clue as to what one needs to do as far as the infection management is concerned. Similar patient. This is a 16-year-old, has fever for 10 days, no focus of infection, a bit lethargic, sorry, a bit lethargic, but otherwise clinically stable. Liver is 2 centimeters. Again, look at the WBC count. Now it's the neutrophils here, which are low. So it's, if you look at the absolute neutrophil count, it is less than 1,000. Now, neutropenia can occur either because of some treatment administered, like we have neutropenia following chemotherapy or neutropenia in a patient with marrow failure syndromes. That neutropenia is different. That is a serious medical emergency. Neutropenia can occur as a result of infection in an otherwise normal individual. So, neutropenia due to infections, again, as I said, viral pathogens or common viral pathogens can produce a variety of problems ranging from thrombocytopenia, pancytopenia, individual cytopenias. But in this case, if you look that the patient has fever for 10 days, now that's unlikely to be because of any viral infection. So in this situation, the possibilities of enteric fever and brucellosis needs to be considered. So patient having fever more than a week with neutropenia, these are the two pathogens that one would entertain at the outset and evaluate accordingly. So the presence of neutropenia in this case would be an important clue towards diagnosing these pathogens. Anemia and infections, and this can be a talk in itself. It's a vast topic. Just to highlight certain factors, anemia may be because of hemolysis. It could be because of chronic blood loss, because of worm infestation, or there could be marrow suppression because of the infections. I wouldn't go into all the details, just highlight some of the factors. Clostridium perfringens infection can occur in children with intravascular hemolysis, so the patient may have fever, red urine, and a sudden drop in hemoglobin with jaundice. And such children, one should look for clostridial infections. Cold agglutinins because of mycoplasma, or warm autoantibodies because of CMV, EBV, or HIV may also occur. Two conditions I will discuss a little more detail is paroxysmal cold hemoglobinuria and transient erythroblastopenia of childhood. So what is paroxysmal cold hemoglobinuria? Not to be confused with the paroxysmal nocturnal hemoglobinuria, which is a different disorder. PCH, or paroxysmal cold hemoglobinuria, is it's a rare form of autoimmune hemolytic anemia, more commonly seen in children than adults. It is characterized by a cold reacting IgG antibody, which binds the red cells at 4 degrees and causes hemolysis at 37 degrees. It's called as a Donat-Landsteiner antibody. Most often is triggered by common viral pathogens. And the onset is usually during the recovery phase of the infection. These children often have rapid onset of pallor along with hemoglobinuria, hepatosplenomegaly, and icterus. And there are two specific features which can give important clues to the presence of PCH. One is neutrophil erythrocyte rosetting, seen here, and neutrophil erythrophagocytosis. These two features are very suggestive of PCH. So if one gets these findings on the peripheral smear, one should consider looking at the specific test for Donat-Landsteiner antibody. A DCT, a direct Coombs test, would be positive if it's done with a complement reagent, but when done with IgG, it should be negative. But most of our DCTs today are bispecific, so we will not be able to differentiate unless we do a specific test. This is a self-limiting condition and may require transfusion support for a short time, but otherwise requires no other treatment. Coming to transient erythroblastopenia of childhood, this is a form of acquired pure red cell aplasia, usually in children. There's occurrence of a normocytic normochromic anemia in otherwise healthy children. There is no evidence of blood loss, there's no evidence of hemolysis or other causes of marrow suppression. And in most cases, an infectious cause is described. Nowadays, we're diagnosing this less and less because now we have our ability to diagnose viral infections is much better. So we would rather label this as a pyrovirus-induced marrow suppression or an HSV6-induced marrow suppression and so on. But this is one situation where one can think about when faced with such a situation that there could be an underlying viral etiology. Because it is transient, it's likely to be underdiagnosed. Child may tolerate the sudden onset of anemia for a short period of time, but it would cause problems in patients having pre-existing hematological disorders like thalassemia or sickle cell, or having an immunodeficiency, which could cause an increase in the duration of the before the virus gets cleared. The next case is a 10-year-old child has fever for 1 week. This child is sick, has a toxic look. Spleen is 2 centimeters palpable. There's no other focus of infection. The cultures are negative, and the child is on broad spectrum IV antibiotics. Look at the WBC. What we see is a pancytopenia. A couple of days later, the child worsens. has developed hypotension, requires vasopressors, and is now in the ICU. So this is basically a very sick child having pancytopenia or a worsening pancytopenia. So what are we likely to be dealing with? Is this worsening bacterial sepsis? Now, in children, except in the neonatal period, in the neonates, overwhelming infection can cause the WBC count to be suppressed. But otherwise, other than the neonatal period, in most situations, you wouldn't get a pancytopenia just because of a worsening bacterial sepsis. So this should not be labeled as bacterial worsening sepsis. Viral infections can produce pancytopenia as a common factor responsible for pancytopenias. However, the course of events is not very consistent with that of a viral infection, but except dengue infection possibly, which should be considered. Malaria should always be considered in the differential diagnosis of a sick patient with pancytopenia. But another possibility which needs to be considered and which is more likely in this situation is what is called as HLH or hemophagocytic lymphohistiocytosis. Now, what happens in a normal immune response on the left side, you can see, the infectious trigger leads to activation of the immune system, especially the cytotoxic T cells and the NK cell. And through series of processes, there is the target cell infected cell is targeted and destroyed. And once the target cell is destroyed, the immune response gets switched off. So because of some mutations or some abnormalities in the entire process somewhere, what happens is after activation, there is failure to elicit or ensure that the target cell gets killed. And so the immune response keeps on getting perpetuated and gets uncontrolled expansion. A lot of cytokines are released, and this leads to a clinical picture of HLH. Also, in some situations, can be called as macrophage activation syndrome. It is characterized by fever, splenomegaly, cytopenias. Hemophagocytosis may or may not be demonstrable on the marrow. And very high ferritin values are the hallmark of this disorder. And as you can see, more than 50% of the causes for secondary HLH are infections. And most common infections that we see are salmonella, dengue, EBV, CMV, and so on. But any infection can potentially predispose the patient to HLH. The talk cannot be complete unless we make a mention about COVID-19, the pandemic raging in the community at present. There are a variety of hematological manifestations associated with detail because there are two subsequent talks on this. But I just want to highlight that these manifestations are not specific for COVID, but they may help in prognosticating the outcome. Lymphopenia and elevated T dimers are two important prognostic variables, and the degree of elevation of T dimer, the depth of lymphopenia would correlate with severity of infection. They can also be used for monitoring response to treatment, and worsening T dimer would indicate potentially worsening clinical situation. In children, we do not see too much of a problem in children. We do not see much of a problem in the acute infection. But what we see more often is a late sick or pediatric inflammatory multisystem syndrome, PCS, which in which these hematological abnormalities like lymphopenia, neutropenia, thrombosis, etc., can occur. Hematological manifestations of dengue infection, another common infection. Thankfully, we are not seeing too many cases nowadays, but this can be another important infection. This is characterized by raised hematocrit, thrombocyte. The typical manifestations are raised hematocrit, followed later by thrombocytopenia. This thrombocytopenia may be because of decreased production, or there could be increased destruction, either immune mediated or otherwise. leukopenia, atypical lymphocytosis, and coagulopathy are also some of the common manifestations. However, in addition to this, patients of dengue can manifest with HLH, can have an overt DIC, pancytopenia, hepatosplenomegaly, and dengue can sometimes trigger ITP just like any other infection can. The bleeding in dengue is multifactorial. There is predominantly because of thrombocytopenia, but there would be a associated platelet. There is believed to be an associated platelet dysfunction also. There is, in addition, there is coagulopathy and vascular damage, which contributes to bleeding. As a result of this multifactorial etiology, it is seen that platelet transfusions are not really useful because they're just going to take care of a single aspect of the pathophysiology. So to manage, avoid steroids, avoid NSAIDs. There is no role for prophylactic platelet or FFP transfusions. The benefit of platelet transfusions for minor bleeding is questionable and should not be done. And these transfusions should be reserved only in cases of major bleeding or if patients are being subject to any invasive procedures. I'll skip this for want of time. Just going back to the next slide. Hematological manifestation of congenital infections. The TORCH group of infections can present with hepatosplenomegaly, a petechial rash. Thrombocytopenia is a prominent manifestation of congenital infections. Perinatally acquired infections, especially just around birth, can present with a leukoerythroblastic blood picture, in which one would see immature precursors of both the erythroid and myeloid lineage. So presence of leukoerythroblastic blood picture in a neonate would prompt us to look for a perinatally acquired infection. So just to conclude, we have we've seen that hematological manifestations are common in children with infections. Very often they are just a source of anxiety, but do not cause any major issues. It can be a very important clue to diagnosis, assessment of recovery, as well as the prognosis in the patient. Some of these manifestations may require specific treatment, but the treatment should be reserved only for specific selected cases. It is important to look at the absolute counts and not the percentage. And another factor which I failed to highlight was that one should look at age-related values, because whenever you look at whether the child has neutrophilia or the lymphocytosis, it could just be normal for that particular age. So always check age-related values before we decide whether there is an abnormality or not. With this, I thank you.
Thank you, Dr. Karminde, for such elaborative information about this thing. There is one question for you from Dr. Deepak. Role of IL-6 in HLH as marker of cytokine release.
Yes. In the current diagnostic criteria for HLH, IL-6 is not a criteria considered. It is not necessary for diagnosis, but it would definitely be elevated. IL-6 can be elevated in infections and inflammatory conditions. So use of IL-6 to distinguish between infections and inflammation is difficult. So it could be a marker of like after treating with steroids or a patient is not responding. If IL-6 is still high, one could at that time consider whether to add tocilizumab or something like that. But to distinguish, use IL-6 to distinguish or to say that this is HLH is not it's not very useful, because very high values can occur in infections also. However, after looking at the entire spectrum, looking at the clinical features, looking at the cultures, looking at the viral markers, if all that is negative and IL-6 continues to remain high, then the possibility of HLH or a cytokine storm can be considered.
Thank you, Doctor. I think Dr. Jayan's is satisfied. I have one question for you. as a incidence of COVID is increasing in the pediatric age group. So apart from the adult investigations, what specific investigation you will advise in children?
So, even now, uh, incidence of severe acute COVID infection in children is limited. It's not very, and most of the management is what we would do for adults. What happens is that there is a late rate of COVID in children, and these children may manifest with either hypotension, cardiac disturbances, rash, prolonged fever, and may not have the recent or may not have acute infection evidence of COVID infection, but they will have old infection. So they will have antibodies to the. So in that situation, one needs to look at antibodies in a child who has a prolonged fever or a multi-organ dysfunction, especially cardiac, neurological, gastrointestinal, cytopenias. If a child has these features in the present scenario, one should look at COVID antibodies in adults. That probably would not be done in an adult. But otherwise, most of the acute infections are the acute investigations are the same.
Thank you.
Thank you, Shailesh sir, for your elaborative and excellent lecture. I request Marty sir to felicitate Dr. Shailesh sir. Thank you, sir. I request Date sir to felicitate our chairpersons for the first session. Date sir, please. Date sir to felicitate Dr. Marty sir, our immediate past president. Date sir is felicitating Dr. Shubhangi Kothari madam, chairperson and chairman of IMA WDW. Thank you, sir. Thank you, madam. Thank you, sir. And thank you, Date sir, for felicitations. Now we'll have a small program of 15 minutes about inauguration and Spandan release. Spandan is a quarterly bulletin of IMA PCB, and it has various inventive subjects every time. Can we have the function, sir? So we are fortunate to have Dr. Ramakrishna Londe sir, as a chief guest. He is the president of IMA Maharashtra State. Sir is attending webinar online. Piyush, can you confirm that he's online? He's online? Okay.
Yes,
Welcome,
I am
sir.
here.
Yes, he's here.
Yes, I am here only.
Yes, sir. Thank you, sir. I welcome and request our guest of honor today, Dr. Ravindra Kute, sir, Vice President, IMA Maharashtra State, to be on the dais. Sir, please. I welcome Rekha Dubey, Madam, CEO, Aditya Birla Memorial Hospital. She is our another guest of honor, but due to her prior commitment, she could not attend the function. But she's always been a consistent support for us. Thank you, Madam. I request Kamath sir, veteran IMA PCB, to be on the dais. Sir, attending webinar online. Welcome. Sir is even the MMC observer today. I request Dr. Date sir, President IMA PCB, for inaugural function. Welcome, sir. I request Dr. Suhas Mate sir, immediate past President IMA PCB, to be on the dais. Thank you, sir. I request Dr. Mandar Dolfode, Secretary IMA PCB, to be on the dais for function. I request Anu Kalia madam to be on the dais for the inaugural function. She's a cardiologist here in Aditya Birla Memorial Hospital. I request Dr. Vijay Satav sir. He is chairman of today's webinar, Haematology Updates, for the inaugural function. And Dr. Shailaja Mane madam, she is the secretary of today's webinar. Thank you all. Can we have a digital lamp lighting, Piyush? Thank you, Piyush. Now we'll have the felicitations of our guest of honor. I request Dr. Date sir to felicitate Dr. Kute sir. He is the guest of honor today. I'll request Dr. Shailaja Mane madam to felicitate Anu Kalia madam. She is representing Aditya Birla Memorial Hospital, who's been a consistent support for us. Thank you, ma'am. I request Dr. Santosh Latkar sir, who's the editor of the Spandan, to come on the dais for the Spandan release function. And I request Dr. Manisha to accompany him, being the Spandan editor. I request the dignitaries on the dais to release the Spandan.
टेस्ट असते ना.
पुढे ये ना.
हेमंत ये ना. हेमंत पुढे ये.
Thank you, sir. Thank you, all the dignitaries. May I request Dr. Santosh Latkar, sir, to speak few words about this Spandan?
हॅलो. आदरणीय लोंढे सर, आदरणीय कुटे सर, आपले पेट्रन डॉक्टर कामत सर, डॉक्टर दाते सर, डॉक्टर माटे सर, डॉक्टर मंदार, डॉक्टर हेमंत, डॉक्टर सातव सर, डॉक्टर शैलजा माने, आदरणीय व्यासपीठ आणि मित्रांनो, दिल ना उम्मीद ही नहीं नाकाम ही तो है, दिल ना उम्मीद ही नहीं नाकाम ही तो है, लंबी है गम की शाम मगर शाम ही तो है. अर्थात हे जे निराशेचे मळब जे साठलेलं आहे आणि ही जी अंधारी रात्र आपल्या समोर आलेली आहे ही रात्रच आहे. कधी ना कधी याच्यातून आपल्याला आशेचा किरण नवीन समोर येणारच आहे. त्यामुळे आपण नाउमेद होऊ नये. तर हा आशेचा जो संदेश फैज अहमद फैज यांनी दिलेला आहे त्या संदेशासोबतच आज आपली IMA PCB ची नवी टीम नव्या उत्साहानं नव्या जोमानं नवीन वेबिनार घेऊन आलेली आहे. IMA PCBचा आपला जो नेहमीचा पायंडा आहे की आपण प्रत्येक वेळी नवीन विषयावरती वेबिनार करतो आणि त्या विषयालाच आपलं स्पंदन ही हे असतं डेडिकेटेड असतं. त्यानुसार यावेळेसचं स्पंदन आपलं हिमॅटॉलॉजी या विषयावरती आहे. या संदर्भात थोडं सांगण्याची जबाबदारी आणि माझ्यावर दिलेली आहे. त्यामुळे स्पंदनची थोडीशी तोंड ओळख करून देतो कारण जास्त वेळ आपल्याकडे नाहीये. तर मुखपृष्ठापासूनच बघा, याच्यावरती तुम्हाला दिसेल बहावा इथे फुललेला आहे वरच्या हाफमध्ये. आजकाल जर तुम्ही बघितलं ऊन प्रचंड तापलेलं आहे, पण थोडं जर तुम्ही सरकारी नियमानुसार थोडं पुढे कुठे बाहेर पडलात तर तुम्हाला जागोजागी हा बहावा फुललेला दिसेल. तर अशा ह्या आशादायक वातावरणामध्ये IMA PCB ची टीम डॉक्टर दाते यांच्या नेतृत्वाखाली आता नवीन कामगिरी पार पडणार आहे. आणि त्याच्या खाली तुम्ही बघितलं तर आपल्या रक्तातल्या लाल पेशी दिसतात सगळ्या आरबीसीस आणि ते या आपल्या हेमॅटॉलॉजीचं वैशिष्ट्य आपल्याला सांगणार आहे. आतमध्ये या स्पंदन बद्दल बोलायचं ठरवलं तर 19 लेख आणि कविता आपल्याला याच्यामध्ये मिळालेल्या आहेत. प्रत्येक लेखाचं सांगोपांग वर्णन करणं थोडंसं अवघड आहे. त्याच्यामुळे मी थोडक्यामध्ये सगळ्या माझ्या लेखक मंडळींचा आभार मानतो. माझे आभार माझ्यासाठी आशीर्वाद आणि सपोर्ट देणारे डॉक्टर कामत सर, डॉक्टर दाते सर, डॉक्टर माटे सर, डॉक्टर सुधीर भालेराव आणि डॉक्टर माया भालेराव यांना सुद्धा मी दुसरे आभार मानणार आहे. माझे जाहिरातदार आदित्य बिर्ला हॉस्पिटल आणि रेखा दुबे मॅडम आणि त्यांची टीम, मेगा विजन आणि त्यांची टीम, कृष्णा डायग्नोस्टिक्स आणि त्यांची टीम, लाईफ सेल आणि त्यांची टीम आणि डॉक्टर हेमंत पाटील यांचं हेरंब हॉस्पिटल. या सगळ्या जाहिरातदारांच्या सहकार्याशिवाय स्पंदन काढणं शक्य नाही. त्यानंतर आभार मानेन माझे संपादकीय मंडळ डॉक्टर मनीषा, डॉक्टर अर्चना आणि आमच्या टीम मध्ये नव्यानं सहभागी झालेली डॉक्टर वर्षा. जाता जाता सिंहासन चित्रपटातल्या काही सुंदर ओळी मला उद्धृत करायचा मोह आवरत नाहीये. उषक काल होता होता काळ रात्र झाली. पहिल्या करोनाच्या वेव्ह मधून आपण बाहेर येता येता पुन्हा सेकंड वेव्ह आलेली, ही काळ रात्र आपल्यावर आलेली आहे. अरे पुन्हा आयुष्यांच्या पेटवा मशाली. तर हा आशादायक संदेश देऊन मी माझे शब्द संपवतो. जय हिंद, जय महाराष्ट्र.
थँक्यू संतोष सर, तुम्ही नेहमी छान बोलता. I request Dr. Ramkrishna Londe sir, President IMA Maharashtra State, to guide us Sir is in a hurry, so he'll be speaking initially. Piyush, can we have Dr. Ramakrishna Londe, sir? Please unmute him. Yes.
Okay. Yes, am I audible?
Yes.
Yes.
ऐकायला येतंय का?
हो सर.
Okay, thank
हो सर. हो सर, ऐकू येतं. अनम्यूट करायला लागेल.
हा. प्रायोरिटी करतो एडिटरचं. त्यांनी खूप चांगल्या प्रकारे स्पंदनचं वर्णन केलं आहे. निश्चितच ते चांगलंच असणार आहे. मला ते प्रत पाठवा, कारण तुमचं गेल्या वर्षी मी पाहिलंय स्पंदन आणि ते आणखीन चालू आहे सांगायचं म्हणजे. आणि दुसरी गोष्ट डायट पण मी ते यूज करतोय माझ्या डे टू डे. आदरणीय व्यासपीठावरील गण्यमान्य व्यक्ती, IMA चे व्हाईस प्रेसिडेंट, IMA चे व्हाईस प्रेसिडेंट आमचे मित्र रवींद्र कुटे सर, आजच्या कार्यक्रमाचे इन्व्हायटी आणि टीमचे लीडर डॉक्टर संजीव दाते सर, त्याचबरोबर त्यांच्याबरोबर काम करणारे धडाडीचे त्यांचे सचिव डॉक्टर मंदार डोईफोडे सर, आमचे स्टेट सेक्रेटरी डॉक्टर बंदरकर सर, आदित्य बिर्लाचे CEO आदित्य बिर्लाचे CEO दुबे मॅडम, आणि आजच्या कार्यक्रमासाठी विशेष करून तुम्ही हिमॅटॉलॉजीवर जो विषय काढलेला आहे, हिमोफिलिया हा आमचा पेरियडिकचा विषय आहे. तुम्ही तो घेतल्यामुळे तुमचं मी अभिनंदन करतो. त्यातील गण्यमान्य स्पीकर्स, मान्यवर, प्रथमतः आजच्या वेबिनार मार्फत व्हर्च्युअली तुमच्या कार्यक्रमाचे उद्घाटन झाले, नवीन ऑफिस बेअरचं टेकओव्हर झालं आणि स्पंदनचंही रिलीज झालं. त्या असं मी IMS तर्फे जाहीर करतो, शुभेच्छा देतो आणि 2 शब्द सांगायचा प्रयत्न करतो.
थँक्यू सर.
मित्रांनो, सरांनी सांगितल्याप्रमाणे उशिरा काल होता काल रात्र आली. आपण तर मेडिकल भाषेमध्ये योद्धेच आहोत. आपण डेली आपण वेगळ्या आजाराशी झगडतो. ऑपरेटिव्ह असो, फिजिकली असो, आपल्याला ती सवय लागली, युद्धाची सवय लागलेली आहे. आणि त्याच्यामध्ये हा कोरोना नावाचा जो एक भयंकर मायक्रो ऑर्गॅनिझम म्हणून आपल्या परेशानी करू लागलेला आहे आणि त्याने आपल्यामध्ये दुरावा निर्माण केलेला आहे. तरी परंतु वेबिनारच्या माध्यमातून आपण एकमेकाशी संवाद साधू शकतो आणि ह्या वेबिनारच्या माध्यमातून वेगवेगळ्या नॉलेज आपण घेऊ शकतो. दुसरी गोष्ट, या कोरोनामुळे आपल्याला मानवी मूल्य काय ते समजू लागलेले आहे. या वर्षी कोरोनामुळे प्रत्येकाच्या कुटुंबामध्ये जवळचा असो, लांबचा असो, मेडिकलचा असो, नॉन मेडिकलचा असो, माणूस गेलेला आहे, आपली मनं दुखावलेली आहेत. तरी परंतु ते दुःख आपण पचवून नव्या जोमाने, नव्या दमाने आपण आणखीन आपल्याला सामोरं जायचं आहे. येणाऱ्या पिढीसाठी आपल्याला आणखीन काम करायचं आहे. आणि मला खात्री आहे 1-2 महिन्यामध्ये दीपावलीच्या आसपास, अगोदरच दसऱ्याच्या आसपास आपण निश्चित ह्या कोरोनावर मात करू शकू. आणि जाता मला एवढं सांगायचं आहे की लसीकरणानं, वॅक्सिनेशननं जर हे कंट्रोल झाला असतं, परंतु दुर्दैव आपलं असं आहे की आपल्याला ते व्हॅक्सिन बरोबर मिळालेलं नाहीये. तर आपण आशा करूयात लवकरात लवकर आपल्याला व्हॅक्सिन मिळेल आणि आपण पहिल्यासारखे कामाला लागू, एकत्र भेटूयात. मी निश्चितच वेळ मिळाल्यानंतर मी तुमच्या ब्रँचला भेटेल, तर आम्हाला आवडेल. तुमची ब्रँच भयंकर व्हायब्रंट आहे. सांगायचं म्हणजे जेव्हा पुण्याला येईल किंवा मुंबईला जाताना येईल तेव्हा निश्चितच तुम्हाला तुमच्या ब्रँचला कुठे सरांच्या बरोबर मी निश्चितच भेटेल. मला आनंद होईल आणि परत एकदा तुमच्या कार्यक्रमाला मी शुभेच्छा देतो. जय हिंद, जय IMA.
Thank you, sir. I request Dr. Date sir for his inaugural speech.
Good afternoon. President IMA MS, our chief guest Dr. Ramakrishna Londe sir, Vice President Dr. Ravindra Kutte sir, CEO of ABMH Dubai madam, and all my delegate friends and the dignitaries on the dais and off the dais.
everyone knows that because of the COVID-19 epidemic, we have to meet virtually online for our meetings as well as for our CABs. This time, I got the opportunity to have dialogue with you through the first webinar of our tenure 2021-22, which is mainly highlighting on hematology update and challenges in hematology in this COVID period. It gives me an immense pleasure to work as a president of IMA PCB, a dynamic and vibrant branch which started in 2014 with a small branch with only 35 to 37 members to start with, and now in last 6 years we have reached more than 750 members. So it is really, we are proud of this, that we could make this branch to go into the category of big branch of Maharashtra state. This is all because of our beloved patron, Dr. Kamath sir, who every year to each and every president, he gave us a good guidance and how to work and how to go ahead. That was really a great encouragement which was given by him to us as well as by our past presidents, Dr. Devdar and Dr. Kamath, Dr. Mate sir. I will definitely fulfill the responsibility put on my shoulders. It is really a great pleasure to work with you all and serve the society in this difficult situation of COVID-19 pandemic. हाती गेल ते तडीसन्या असं आम्हाला एक शाळेमध्ये ब्रीदवाक्य कायम होतं की जे आम्ही आयुष्यभर सांभाळलेलं आहे आणि त्याच्या अनुषंगाने पावलावर पाऊल टाकून आम्ही आमचे 100% कुठलीही काम हाती घेतल्यानंतर ते पूर्ण करण्यासाठी योगदान देतो. I assure you that IMA PCB will shine with bright colors in Maharashtra state by its signature projects and the activities in the entire tenure. We started our tenure with free vaccination camp in Park Street Society, followed by vaccination information posters. That drive we gave the free posters we distributed in different societies, different companies. Then we took a webinar on safe motherhood, safe child and safe family, Nurses Day celebration, free rapid antigen test drive was also conducted in the last week, and about 570 policemen were freely checked with the help of Dr. Sathav's laboratory and regarding the RAT. I really congratulate and give special thanks to our patron, our past presidents, and my most enthusiastic executive committee members for their excellent guidance and support and their dedicated work. We could do all these projects in last 1.5 months. I am very glad to communicate with you all through this webinar and Spandan, and I wish you all a healthy, wealthy, and safe future life. सर्वेपि सुखिनः सन्तु, सर्वे सन्तु निरामयाः, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखमाप्नुयात्. धन्यवाद. जय IMA, जय हिंद.
Thank you, sir. I request Kamath sir to guide us if he is available online. Kamath sir, please. Piyush, can you make sure that sir is there? Kamath sir. Meanwhile, can we have a felicitation of Dr. Shubhangi Kothari, madam? She is a new chairman of IMA Women's Doctor Wing at the hands of Dr. Date sir. Ma'am, please. I request Date sir to felicitate Dr. Shubhangi Kothari, madam. So I request I request Dr. Ravindra Kute sir, Vice President IMA Maharashtra, for his speech.
Good morning, everyone. It's my proud and privilege to be here amongst you on the occasion of a webinar and release of Spandan by IMA PCB branch. President Dr. Sanjeev Date sir, Secretary Dr. Mandar Doifude sir, Treasurer Dr. Hemant Patil sir, immediate past President, my batchmate Dr. Suhas Mate, patron, our guide, mentor, Dr. Dilip Kamath sir, senior gynecologist, and he is observer for today's webinar. President IMAMS, Dr. Ramakrishna Londe sir, Rekha Dubey madam, but she is not present, and Dr. Kale madam is there on behalf of Aditya Birla Hospital. Kothari madam, Chairman Women's Doctor Wing, all the dignitaries on the dais, and all the delegates. Today's CME, we are arranged on a special topic, hematology. 17th May was World Hemophilia Day, and accordingly, we are arranged a CME on hematology. Hematology helps us in diagnosis and management of various diseases, even in the dreaded disease, COVID. We have got excellent speakers, and I had an opportunity to listen to two of the speakers of today's webinar, Dr. Sandeep Bandarke sir, Bhatake sir, Dr. Suraj Goenka sir, Dr. Shailesh Kanvinde sir, coordinator for today's webinar, Shaila Jamane madam, Vijay Satav sir. Anandachi goष्ट अशी more than 270 delegates, they are attending this webinar. Secondly, I will congratulate organizers for selecting a nice venue and with a good decorum. There are 218 branches in Maharashtra, and ours is, the code number is 233. मधल्या काळामध्ये काही छोट्या ब्रांचेस जे आहेत त्या डिस्ट्रिक्ट ब्रांचेस मध्ये मर्ज झाल्या, and now the figure has gone down to 218. त्यापैकी 34 ब्रांचेस मी तयार केलेले आहेत. मला आनंद असा होतोय का पीसीबी ब्रांच बरोबर सुद्धा देखील ऋणानुबंध आहे. हे सुरू होण्याच्या आधी मी सुहास बरोबर विषय काढला होता का व्हाय नॉट टू हॅव IMA PCB ब्रांच, आणि 2-3 वेळा हे डिस्कशन नंतर कदाचित त्याच्या समोर एक भीती होती काही ते पिंपरी चिंचवड डॉक्टर्स असोसिएशन फार स्ट्रॉंग आहे आणि हे लोकांना काही वाटेल का काय IMA आपण ब्रांच काढल्यानंतर. परंतु हळूहळू ती भीती दूर झाली आणि नंतर पुढच्या गायडन्ससाठी एक प्रॉपर चॅनल मधनं IMA पुणेच्या माध्यमातून आणि सहकार्याने ही ब्रांच या ठिकाणी उभी राहिलेली आहे. नवे गेल्या 7 वर्षामध्ये त्यांना एक चांगलं उडान घेतलेलं आहे असं मला सांगावं. ही एकमेव ब्रांच अशी आहे की जे सिन्स इन्सेप्शन स्पंदन सारखं सुंदर असं बुलेटिन रिलीज करतात. दॅट इज द युनिक ब्रांच इन महाराष्ट्र. गेले 7 वर्ष आपण हे पब्लिश करतोय. माझी एडिटर माया भालेराव मॅडम देखील या ठिकाणी उपस्थित आहेत आणि प्रेझेंट एडिटर डॉक्टर सर, मी तुमचं अभिनंदन करतो. तो सुंदर असं कॉंग्रॅच्युलेशन सर. त्याच्यामध्ये सुंदर असे आर्टिकल्स आहेत आणि अकॅडमिक सोडून बाकीचे देखील आपण या ठिकाणी सुरुवातीपासून भालेराव मॅडमच्या पिरियड पासून आपण त्या अदर एक्स्ट्रा करिक्युलर गोष्टी आपण या ठिकाणी सामावलेल्या आहेत. Regarding installation, it has been postponed because of the COVID situation. But on this occasion, I'd like to congratulate Dr. Sanjeev Date sir, who is a consulting surgeon, Dr. Mandar Doifode sir as secretary, senior gastroenterologist, treasurer Dr. Hemant Patil, orthopedic surgeon, president-elect Dr. Sato sir, and their team. Congratulations, Dr. Kothari madam, chairman women, Dr. Wing, and all the team of IMA PCB. Congratulations for a wonderful and successful, memorable 2021. IMA PCB, I will be concluding in half in a minute. IMA PCB, the membership is 750, and अजून एक वैशिष्ट्य IMA PCBचं आहे तर पहिल्या वर्षापासून ही अवॉर्ड विनर ब्रांच आहे. दरवर्षी कुठलं ना कुठलं अवॉर्ड हे घेऊन येणार आणि मागच्या वर्षी 5 अवॉर्ड घेऊन आले. So there is a continuous growth, development of IMA PCB branch. We are having CGP wing, we are having AMH chapter, we are having social security scheme, women's doctor wing, but my sincere request to start with PPS, professional protection scheme. आपण ऑलमोस्ट आठवड्यातून 2-3 घटना सध्या बघतो तो कुठल्या तरी हॉस्पिटलवर अटॅक झालेला आहे, स्टाफला मारहाण झालेली आहे आणि त्यातलं कामामध्ये परवाच औरंगाबादला अशी घटना घडली, नाशिकला घटना घडली की ते कारच घेऊन गेला त्या हॉस्पिटलमध्ये एका नगरसेविकेचा पती. तर अशा डिस्टर्बिंग घटना ह्या वारंवार घडतात. आपण सर्वजण स्ट्रेस खाली पेशंट मॅनेजमेंट करत असतो आणि अशा ज्या उपद्रवी घटना आहेत हे बघण्यासाठी कुणीतरी आपल्याला मदतीचा हात लागतो आणि तो मदतीचा हात आपल्याला प्रोफेशनल प्रोटेक्शन स्कीमच्या माध्यमातून मिळणार आहे. माय सिन्सिअर रिक्वेस्ट टू दी ऑफिस बेअरर्स, काइंडली लुक आफ्टर PPS. सेकंड इज नॅशनल हेल्थ स्कीम. दोनच स्कीम बद्दल मी थोडा आग्रह राहणार आहे. हा जो खर्च आहे कोविडचा सध्या आपण बघतोय दॅट इज इन लॅक्स आणि काही मोजके लोक सोडले तर बाकीच्यांना हा फारच तसं अवघड आहे. आमच्याकडचे काही लोक इकडे पुण्याला येतात, ऍडमिट होतात and they have to spend up to 7 lakhs, 8 lakhs, 10 lakhs. आणि हा जो अवाढव्य खर्च आहे, नॅशनल हेल्थ स्कीम ऍप्लिकेबल आफ्टर MBBS टिल द एज ऑफ 80 years. अशी कुठली स्कीम नाही, असं कुठलाच इन्शुरन्स स्कीम नाही की जी 80 वर्षापर्यंत ऍप्लिकेबल आहे. आणि त्याचा प्रीमियम हा सुद्धा कमी आहे. जेवढा अर्ली एज मध्ये आपण सुरू करू तेवढा त्याचा प्रीमियम कमी आहे. 25 ते 30 वयोगटात आपण सुरू केले तर 2,500 रुपये प्रतिवर्षी त्याचं इन्स्टॉलमेंट आहे. इतकं कमी इन्स्टॉलमेंट आहे. आणि सगळ्यात महत्वाचं वैशिष्ट्य का कुठलाही अॅक्यूट इलनेस असेल, इंजुरी असेल किंवा मायकार्डियल इन्फेक्शन असेल किंवा स्ट्रोक असेल किंवा रिनल डॅमेज असेल तर 2 लाख रुपये इमिजिएट रिलीज करणारी ही एकमेव स्कीम आहे. आणि कशावर रिलीज होतात? ओनली सेक्रेटरीज लेटर, so and so he is a member of IMA PCB branch and his life membership number is so and so, he is suffering from such and such disease. तर 2 लाख रुपये आपल्याला इमिजिएट त्या ठिकाणी रिलीज होतात आणि अजून 1 लाखापर्यंतची मदत त्यांच्याकडनं मिळू शकते. म्हणजे असं 3 लाखापर्यंत मदत करणारं ही एकमेव स्कीम आहे. आणि मला नाही वाटत असं दुसरं कुठलं स्कीम असेल किंवा बाहेरचं कुठला तरी असं एखादा इन्शुरन्स हे असेल पॉलिसी अशा प्रकारे इमिजिएट आणि नुसते आपल्या लेटरवर रिलीज करणार आहे. अजूनही आपल्या बऱ्याचशा स्कीम्स आहेत, 15-20 स्कीम्स आहेत. फॅमिली वेलफेअर स्कीम किंवा पेन्शन स्कीम ह्या आपण क्रमाक्रमाने आपल्या ब्रांचमध्ये ऍड करत जावा. अलॉंग विथ वेबिनार. वेबिनारचं इम्पॉर्टन्स फक्त आता 5-10% आहे, परंतु आपल्या ज्या विंग्स आहेत, आपल्या ज्या स्कीम्स आहेत, दे आर फॉर द मेंबर्स, दे आर फॉर देअर फॅमिलीज and they are for their profession. या तिन्ही दृष्टिकोनातून ह्या स्कीम आपण वाढवल्या पाहिजेत. सगळ्यात महत्वाचं ऍक्टिव्हिटी रिपोर्ट. आपले जे दरवर्षी अवॉर्ड्स आपल्याला मिळतात नॅशनलमध्ये, तर प्रत्येक महिन्याला ज्या ज्या ऍक्टिव्हिटी आपल्या झाल्या त्या ऍक्टिव्हिटी आपण IMA महाराष्ट्राला रिपोर्ट करत जावं. बेस्ट विशेष फॉर द ऑफिस बेअरर फॉर एक्सलंट टेन्युअर. थँक्यू व्हेरी मच.
Thank you, Kute sir, for your valuable guidance. Your words mean a lot to us. I request Dr. Mandar Doifode sir, IMA secretary, to give vote of thanks.
Just now, I received a phone call from our president that IMA MS is constructing a new building for all the IMA branches to have the good union for the conference as well as for the many cultural or other activities. So they say that IMA PCB should not be behind in contributing it. So I declare 11,000 rupees as a bidding fund to IMA MS on behalf of IMA PCB. So President Dr. Ramkrishna Lande sir, we are ready to contribute 1,000 rupees from IMA PCB for your bidding.
दाते सर, 1 मिनिट सर. धन्यवाद, तुमचा मी आभारी आहे. IMA पूर्ण डॉक्टर मंडळीतर्फे तुमचा मी आभारी आहे. आकडा थोडा वाढीव पाहिजे, तुमची संख्या खूप आहे आणि तुमच्या बाजूला एवढे धडाडीचे कार्यकर्ते आहेत, आमचे व्हाईस प्रेसिडेंट बाजूला बसले, त्यांचे विचार विनिमय करून तुम्ही आकडा वाढवून सांगावा अशी माझी विनंती आहे तुम्हाला. दॅट्स अप टू यू. कुठे सर तुम्हाला मार्गदर्शन करतील.
आमची ब्रांच फार छोटी आहे, ती आता मोठी व्हायला लागली आहे, त्यामुळे आम्ही जसे जसे मोठे होऊ तसं आम्ही पुढे तुम्हाला नक्कीच
मोठे आहेत. आपण मोठे आहात मोठे आहात सगळे आहे. ओके सर, थँक्यू सर.
हा, थँक्यू सर. या हॅलो.
Okay, the inauguration was okay. Online. Online sir. 2 minutes only.
Good afternoon, everybody. That was our patron, Dr. Kamath sir. He was busy with a case, so he called me. He had just got free, so asking whether he can join now or not. So anyway, I am Dr. Doifode, Mandar Doifode. I am the secretary of our IMA PCB branch. I am here to deliver the vote of thanks. So since we are running short of time, I think I should get on to the job right away. So first of all, I would like to thank Miss Dubey, Rekha Dubey madam from Birla Hospital. Dubey madam has always been a big support to our association. Let it be our conferences or our magazine Spandan. Just one request from us, and she's always there to support us. During this webinar also, she readily agreed to allow us to use this ABMH, wonderful ABMH auditorium, along with all the manpower. I really thank you, madam, on behalf of IMA PCB. Then I would like to thank Dr. Londe sir, who is the IMA MS, and Dr. Kute sir, who is the vice president. I want to thank both of them. They have always been supported our association. I thank Dr. Kute sir for coming here in person, and also thank Dr. Londe sir for joining online and gracing this function. Next, I want to thank Dr. Kamath sir. Dr. Kamath sir is the pillar of support for our branch. Any problem of any sort, Kamath sir is always there, and he has a solution for those problems. Then, I would like to thank Dr. Mate sir, who is our immediate past president. He has done exemplary work during his tenure as our president, and we are just following the path laid by you, sir. Next, I would like to thank Dr. Devdar sir, because of his immense contribution he has made to our organization over so many years. Next, I would like to thank our dear president, Dr. Date sir. He has taken on the presidentship this year, but his vast experience in doing this activity has really helped us in our association work. And I am sure under his able leadership will attain newer heights. I would like to thank Dr. Latkar sir, who is the editor of Spandan, and he has done a wonderful job in compiling all the material for Spandan. And I assure you that this Spandan edition has been really wonderful, and you'll all really enjoy reading it.
Lastly, I would like to thank my dear wife, Dr. Manisha. She has been immense support and motivation to me over the years. She's also ably handling our IT department of our branch. In the end, I would like to thank our new executive committee. Friends, let's do a good work this year and help expand our association further. So, in the end, I thank you all for coming here and gracing this occasion. Thank you. So I would like to thank all the attendees who have joined online. So, because of your immense participation, this webinar is becoming really successful. Thank you.
Thank you, dignitaries. The inaugural function is over. Now we are moving on to the second session of lectures. I invite chairpersons for the next section. Dr. Maya Bhalera, madam. Madam is the Executive Vice President, IMA PCB. Maya, madam, please.
Projector. क्या हो रहा है? हिला मत ना. The table hello. Okay, I'm just going to sing so.
Dr. Dilip Kamath sir, IMA patron. He is available online now. He was busy in some surgical work. So can we have 2 minutes guidance from him? Piyush?
Yes, ma'am, he's online.
Yes, sir, you are visible.
Audio on. Unmute.
Sir. Sir.
Dr. Dilip, please unmute.
Hello.
Yes, sir.
Yes, sir.
Hello.
Sir, you are audible.
Sir, your guidance, please. Kamath sir, you are visible.
Hello, Mandar.
Sir, we can hear you. You can go ahead. You can start your presentation. So you need to unmute yourself. सर अनम्यूट करा परत म्यूट झाला तुम्ही
Hello.
Yes sir, you can start.
Hello.
Sir, you are audible, you can start. So we can see you. You can start. You can start your presentation. परत unmute करा.
Hello. Hello. Can you listen me?
हाँ सर येते ऐकू तुम्ही चालू करा.
Hello. Hello.
हो गया ना?
नहीं लगा है अच्छा पेनड्राइव लगा दिया चूक करतोय असं नाही Hello, can you listen to me? नहीं मला हे करायचं होतं कॉपी करायचं हां सर बस बाकी नाही Yeah.
6 number. 6 number लिया म्हणजे आपल्याला
ठीक आहे
नहीं सर नहीं सर
ते मगाशी डाउनलोड केलं त्याचं कुठलं असेल
नहीं सर 13 नहीं.
Hello.
हाँ आवाज है.
Hello, can you listen to me?
Yes sir, we can hear you.
पुन्हा जातो
सर तुमचं हाँ आता सर हाँ you are visible. So you can sir proceed, sir.
दिलीप सर माझा आवाज येतोय? कामत सर माझा आवाज येतोय?
हो पियुष ना?
हो
हा येतोय ना.
नाही कामत सरांना येत नाही, बहुतेक त्याचं व्हॉल्यूम कमी असावं. सो इज नॉट शुअर. Mansa sir, could you please call him and tell him to increase his volume? कामत सर आवाज येतोय?
तुम्ही तुमचा स्पीकरचा आवाज वाढवा. तुमचा चेहरा दिसतो व्यवस्थित, पण ऑडिओ सारखा म्यूट होतो.
हॅलो, ऐकू येत आहे?
हो सर येते येत आहे. क्लिअर. हो क्लिअरली ऐकू येतं.
By the way, now say I'm very sorry that I couldn't attend it of certain reasons, plus my own problems. But I know that this is my baby. Along with Mate, we have started this long back thing, and this is a real thing that every president is going ahead with some or other new things. Now, this is one thing that this is preparing for some good thing which were not there when I started. So it's a thing of glory. Now, on this occasion, first of all, as a past president and a trustee, my good wishes, best wishes are always with you. But as an observer, I can say that, Mandar, I really don't know what's the number. Hello? Hello?
काय सर?
What's the number? How many people are attending?
More than 260 people are participating online.
That's true, but right now, what's the number which are attending at the moment? You know it?
So 256 है दत्ता right now.
Morning, even though I was not visible, I was there and I attended. It's really wonderful speeches for everybody, and I understand that we are going ahead with the things as far as the continuing medical education is concerned. At the same time, to have a good thing for the society. Last but not the least, I'm very sorry, Dr. Kute, who are attending all the way from Sidampur, and we are with you, and we are going to really going to help you whatever you want. You are one of the member of PCD, IMA PCB, I can say. So don't worry as far as our support is concerned. Best wishes for Dr. Kute and best wishes for this managing committee who is holding all this thing. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir. Now it's feeling complete. Now we'll have a second session of lectures. I welcome chairpersons for this second session, Dr. Maya Bhalera, madam. Madam is a senior anesthesiologist here and she's the executive vice president of IMA PCB. Maya, madam, please. I request Dr. Anu Kalia, madam. She's a cardiologist, Aditya Birla Memorial Hospital, Pune, as a second chairperson. Ma'am, please. Thank you, ma'am. Thank you, Maya, madam. Thank you, Anu, madam. Now our fourth lecture is by Dr. Vijay Satal, sir, and his topic is laboratory investigations in COVID-19 infection. Sir has completed his graduation and post-graduation from BJ Medical College in 1996. He is the founder of Dr. Sadhav's Pathology Laboratory. Sir is a senior consulting pathologist in Aditya Birla Memorial Hospital. Sir is ex-professor and PG guide from the Department of Pathology from Dr. Diva Patil Medical College, Pimpri. Sir is president-elect in managing committee right now in IMA PCB. Over to you, Sadhav sir.
Slide. Screen. Screen पर नहीं, खांचा screen पर. एक मिनट. Good afternoon, everybody. I welcome all of you again for the second half of this today's webinar, this hematology update. My previous speakers, Dr. Sandeep Bartake, then Dr. Goenka, they're well covered about the hematological aspect. And my task is to cover the initiation in COVID-19 infection. Before going to this topic, I'll just highlight proper swab collection for COVID antigen, that is from the nasopharynx, should be done. And actually, it's a bedside test where the results are obtained within 10 minutes. All the accessories are provided in the kit along with the manuals or procedures. It should be followed meticulously. Secondly, if you're collecting the swab for RT-PCR, the swab should reach nasopharynx as well as oropharynx to get a good quantum of viruses. Secondly, the most important thing is after collection of these swabs in the VTM, many of the laboratories or the hospitals, they preserve this sample into a refrigerator. There is no need to do refrigeration. All the samples has to be kept at the room temperature before sending it to the laboratory. So coming to the COVID panel, we have to mainly focus on the hematological aspect as well as the serological markers. The CRP, ferritin, D-dimer, LDH, all of us are aware about it. Depending upon the severity and the symptoms of the patients, further investigations are LFT, RFT. If it is an aged patient, more than 50, random sugar, and of course IL-6. But many a times it is observed that IL-6 is done in the first week or first 2 or 3 days, and it is in the normal range. Ideally, it should be done after 1 week of the disease. CBC, an important baseline investigation. Dr. Bartake has very well covered all the aspects. I'll just highlight the main points regarding CBC. As we are seeing many patients with influenza or URTI, you get a increase in the eosinophil count, whereas in COVID infection, there is no eosinophilia. So this is one differentiating point between these influenzas. Secondly, the most important is the NLR. neutrophil to lymphocyte ratio. Normally it is between 1 to 3. As the disease progresses or the disease gets worsened, this NLR goes on rising, and we are seeing a very bad prognosis if it reaches up to 18 or above 18. So this is one of the best marker, hematological marker for this COVID monitoring. The second most important is CRP, that is C-reactive protein, is an acute phase reactant synthesis by the hepatocytes to the inflammatory response. And the titer is very important. If the titer is doubling or it is rising by 3 folds, that means the patient is deteriorating very fast and there is a lot of multiplication of this virus in the respiratory tract. So CRP correlation, if the CRP status remains in the negative within normal range, there is no need to hospitalization. The patient can be very well maintained in home quarantine phases. And if it is doubling, of course, you have to shift the patient to the hospitalization and institute, and further management has to be done. D-dimer, all of us are aware about this marker, mainly increase in conditions like DVT, then pulmonary embolism, DIC. As all of us know that the course of the disease, which is very well explained by Dr. In the previous speech, Dr. Kanvinde, that there is activation of this all macrophages and release of this different cascades resulting into increase in the D-dimer levels. So these are other contributing factors other than COVID infection, which gives to elevated levels of D-dimer. And again, it is one of the most prognostic marker. Ferritin, I'll not go in detail about all this thing. Ferritin, it is said that if the ferritin is on the higher side or it is doubling, patient needs a thorough clinical evaluation. Again, lower respiratory tract has to be screened very well. This is just a diagrammatic presentation. How the ferritin gets generated, will not go in the different steps. Again, indirectly, it represents the tissue damage. All of us are aware about LDH, that is lactate dehydrogenase, one of the important enzyme we are studied in first MBBS, generation of NADPH into NAD, required in almost all the cells. If this marker is elevated in COVID patients, it indicates that the patient is heading towards a acute respiratory distress syndrome, that is ARDS. So it's a foremost indicator for ARDS. So these are the main markers. In between, I'll just like to highlight pre-analytical and analytical errors. This tabular form is very important while reading the reports of different tests. Many of the laboratories, if they are accredited with NABH or NABL, it is mandatory to mention the date and the time of the collection of the sample, date of the time of reporting as well as printing. Why it is important? Because the parameters like D-dimer has to be processed as early as possible within 2 to 3 hours. If it is not processed immediately, the plasma has to be separated and it should be maintained at 4 to 6 degrees Celsius. Same thing is applied for IL-6. These are the different markers. It might index at globally they are used for monitoring this COVID patients. It might be a nutritional or a Glasgow or a prognostic markers. And the most important, if in the rural areas where the markers are not available, NLR is taken as the best marker, NLR and CRP, because nowadays in even also in rural areas. Most of the tertiary labs are also primary labs. They do CBC as well as CRP. Interleukin 6, again, it has, as I had earlier told you, that it should be done after 7 days of the symptoms, which is a good marker or indicator of cytokine storm. If the sample is processed, for example, if it is collected in a secondary hospital and sample processed after 6 hours, the readings are multiplied by 4 to 5 times. So it is advisable to conduct this interleukin 6 test within 2 hours. So false high readings are seen in the patients which are been admitted in the rural areas and their IL-6 is always above 100, but clinically the patient is stable. So the time of collection of the sample and the processing is very, very important in IL-6. This is how it stimulates different cells like cells from the macrophages, then hepatocytes, and T lymphocytes. All these cells are stimulated and the cytokine storm is generated, giving rise to and elevated D dimers and other factors. Along with this, the biochemical markers that LFT and the RFT are also important if there are minor episodes of thromboembolism and unfortunately blocking coronary vessels, you will get a T positive or troponin I positive, CPK-MB on the higher side, changes in the ECG. So the investigation has to be selected according to the clinical symptoms and presentation. Cardiologists know, madam, very well about all these things. At the same time, we are seeing many patients with a multi-organ failure, so we have to keep a close watch on blood urea and creatinine as well as liver enzymes. And this is a graphical presentation. If you administer tocilizumab for cytokine storm, only parameter which remains on the higher side is D dimer. So the other parameters will immediately start falling down, and it's a good prognostic indicator. So in short, if you cut down the steps of doing all this COVID tests, day one diagnosis RT-PCR or antigen. If antigen is positive, there is no need to go for the RT-PCR. Antigen is taken as positive. If the clinical complaints are of more than 4 to 5 days, you have to, on the same day, you have to do all parameters like CRP, CBC, D-dimer, LDH, and other parameters. And this has to be monitored on the 7th day. And that will decide whether the home quarantine of that patient should be continued or the patient should be admitted immediately. And the most important thing is the D-dimer. Many of the literature say that the D-dimer has to be monitored for at least 4 months till the readings comes in the normal range. Coming to vaccination, many people, even medicos as well as non-medicos, they run for total antibodies or IgG-IgM antibodies, which is not advisable. Ideally, we have to do spike protein neutralizing antibodies, that too after taking the second dose of the vaccine after 1 month. If you do in between, suppose you have taken the first dose and doing this antibodies in 15 or 3 weeks, then it will be in the negative phase. The normal titer is 0.8. We are seeing most of the patients or most of the doctors with the titer more than 150. Mucormycosis. Now again, this is one of the greatest complication which all the ENT surgeons are facing. We are getting nasal swabs for mucormycosis. And the clinician, they are just behind the pathologist. they should please tell us the report as early as possible. But please note that your nasal swab will not show any mucormycosis, and that will be a false negative reporting. We require a nasal tissue, preferably from the ENT surgeon, and we can do a KOH mount. It takes 2 to 3 hours for the tissue cells to dissolve and to see the mucormycosis under the microscope. So the turnaround time for this mucormycosis is 3 hours in KOH mount. Of course, for the culture, it takes almost 5 days to diagnose. And on histopathology also, we can confirm very well. We can confirm the margin of the surgical specimens also, whether they are involved by this mucormycosis. Again, if it is a bony tissue, we require another 5 days for decalcification. Whether there is the depth of involvement of the bone can be accessed, but it takes longer time. Now comes the question, many of the patients as well as the doctors, they are worried about post-COVID infection. Since it is a nosocomial transmission, people are worried if, whether that patient is going to transmit to the other family members. So there is no need to do RT-PCR or an antigen test on the nasal swab, because your RT-PCR is definitely going to show a positive result, and this can be for 1 month or 2 months. So there is no need to do RT-PCR or an antigen test. You have to monitor with D-dimer, and most importantly, if you have to have a close watch on blood sugar levels, because if you monitor blood sugar levels very well, the patient will not line into mucormycosis, because again it is a very costly affair for the patient, almost 3 to 4 times than the COVID. Now, because patients are running for amphotericin injections and all these things. So monitoring blood sugar will help a lot for these patients, and HbA1c will also help for this. So these are the different tests, in short, I have covered. And you should be always in touch with the pathologist regarding the parameters, regarding the tests, the different investigations that will help the patient economically as well as for the monitoring purpose. Thank you very much. Thank you very much for the lesson listening. I thank Aditya Birla Memorial Hospital. I thank all the audience for patiently listening my talk, and my chairpersons. And the topic is open for the question and answer session.
Thank you, Dr. Sato. It was a good presentation. There are 2-3 questions on the chat box. We'll read to you. What is the desired level of spike protein antibody titer post-vaccination for protection against COVID-19?
If it is, the normal range is up to 0.8, above 30 is taken as adequate level of this spike protein antibodies.
Okay. One more question is there. Sir, can you guide us principal investigation in COVID infection, that is blood investigation? This question is in the chat box. Please answer.
As I told you that if it is more than 3 to 4 days of illness, primary markers like only hemogram, CRP, LDH, and ferritin, these are enough.
Okay.
And this, out of this, as NLR and all these 3 parameters has to be monitored. The report should be compared with the previous readings. If they are multiplying, then only you have to switch on the higher immunizations like D-dimer, and after 7 days you have to look for the IL-6 for cytokine storm.
7th day.
7th day.
Okay. One more question is there. If the patient is on home isolation, he doesn't have any symptoms. So whether we should go for any investigation or any specific investigation.
Investigations are same. But
even if the patient doesn't have any symptoms.
Yeah, we have to do investigations.
We have to do investigation.
Because many a times the CRP and LDH are within normal limits up to 7-8 days also. But suddenly the patient complains that there is a fever but not responding to the treatment or increase in the cuff or saturation falling down. Again, we have to
No, patient is asymptomatic.
Okay.
So
then there is no need of repetition of the investigation. But so we have to, baseline investigation has to be done once.
Oh, thank you, sir. One more question, Dr. Latkar sir wants to ask you.
Dr. Sato, thank you for touching a very hot topic for ENT, all the ENT surgeons. The mucormycosis is very correctly said about the diagnosis. Now, post-diagnosis, we have some gray areas, like the dissection, whether the dissection is complete or not, whether the disease is progressing or not. Like for that, what we have to do is either we have to go in for repeated MRI, which is again very costly affair, as you very correctly said. So what we rely upon is a serial CRP estimation. So could you please guide how frequently and at what intervals we should do this CRP estimation?
We can do CRP estimation on the alternate day. And one more thing for your mucormycosis. After you are seeing the lesions, if you are thinking of residual infection, you can take the small bits from the margins, surgical margins, and do a KOH mount. It is a cheapest form, not costly affair for the patient. Hardly 200 to 300 rupees is the cost. And that can be repeated n number of times. So that will be the best marker. Again, involvement of the bone, whether only periosteum is involved or whole periosteum is eroded by this mucormycosis, should be mentioned in the HP report. So that will tell us whether you have to extend the disease. Yeah.
Grading we can categorize in that way if the bone involvement is there.
Usually it involves the bone, but the depth of invasion is very important.
And how frequently should we do this serum creatinine and potassium level if the patient is on amphotericin?
Amphotericin you have to monitor with the RFT, renal function, renal parameter, as well as LFT.
And potassium.
Potassium.
But every day is it needed, or maybe alternate day we can
the readings are normal and there are no clinical signs and
readings are abnormal, otherwise.
Then you have
normal
to,
we will not do that.
Then you have to monitor at least 2 times a day. Electrolytes.
Every day.
Yeah.
Every day. More depending on the levels. Thank you, sir.
Definitely.
Yeah, one more question is this, sir. If RT-PCR negative and pro-inflammatory markers are on higher side on day 5 in symptomatic patient, should we consider it as COVID?
It's a very clinical question, sir. You're right. And it's a very common question asked to all the physicians and us. Obviously, even if the patient is RT-PCR negative and if his inflammatory markers are high, it is COVID. Because we know that nowadays we are getting PCR negative COVID. Because there are limitations of PCR, as sir rightly said, I think the sensitivity is close to 60 to 70% if we are doing 2 PCR back to back. Actually, so because of the low sensitivity, so you can miss the PCR can be negative.
Secondly, if the patient is compromised at the liver level, chronic liver diseases, the CRP title also remains on the lower side. And one more thing, actually, in such patients, they do a HRCT, and that score is taken as a major factor for to label it as a COVID or not.
To be precise, more than anything else, if the patient has got suppose fever, body ache, in this current epidemic, you have to consider first 1 to 10 diagnostic criteria as it must be COVID. And if you do not get any other, and if everything is normal, then you can think of second diagnosis. But the first foremost diagnosis, I'm sure Dr. Tondavkar would agree as a physician that it has to be COVID.
Yeah.
Then you try and find out what is the cause by doing, as you rightly said, sir, we need to do CRP and I think CBC and other basic investigations. If they are positive, if there is a saturation problem, if the
saturation
patient
fall is also taken
Yeah.
as one of the criteria.
yeah, saturation is low or patient continues to get cough, then obviously even if RT-PCR is negative, just to prove that the gold standard remains CT scan.
Yes.
We need to do the CT scan if the patient is symptomatic, even if he is RT-PCR negative. We say that he is RT-PCR negative but CT positive. And CT positivity, if you get ground glass opacity, definitely this patient is COVID and we need to treat him on the lines of COVID.
Yeah.
Not only that, nowadays I think in the second wave we have learned so many new things. I'm sure Dr. Tongapar would highlight in his talk that on day 5 or day 7, even if your saturation remains 94, 95, if you continue to get fever of 100 degrees and plus more, then definitely get a CT scan done.
Yeah.
And you may require hospitalization, because do not wait for the saturations to drop below 90. What we used to say, in first waves at 92, 93 is the time we should get admitted. Because these patients rapidly deteriorate on day 10, day 8 to day 12. And they come in cytokine storm, so it's very difficult to treat them, and then the golden time is lost. So it's not just the saturation; it is the symptom, fever, cough, breathlessness. You need to take everything into consideration.
Yes.
A few more questions if time permits, otherwise we'll proceed later on.
Yeah. Thank you once again.
Thank you very much.
Thank you, sir, for a very important and elaborative lecture. Can we have sir's felicitation? I request Dr. Maya Bhalera madam to felicitate Dr. Vijay Sathar, sir. Come. I request Dr. Ravindra Kute sir to be there as a chairperson. Sir, please come on the dais.
Madam, इतना चाहिए कहीं पोस्ट कोविड बरोबर इथं लावले वाटतं नाही सर
Our next speaker today is Dr. Aniruddha Tondgaonkar sir. सरांचं CV असं आहे की आपल्याला त्याचं डॉनचं म्युझिक लावावं लागेल. And but I'll speak something for you. Sir is going to speak on the very interesting topic, that is a post-COVID sequelae, a multi-system involvement. Very important lecture. Sir is the founder director of Sterling Multi-Specialty Hospital. He is the owner and director of Tondgaonkar Hospital, Akodi. He has a huge experience of 23 years, and his primary interest is cardiology, diabetes, and infectious diseases. Sir has worked as a principal investigator in many phase 3, phase 4 trials. Sir has experience of managing thousands of COVID patients. Hats up to you, sir. He's fitness freak. He's a routine marathoner and a very good singer. I welcome Dr. Aniruddha Tondgaonkar sir for his lecture.
Next slide. If we this is next slide. Yeah. At the outset, I would like to thank IMA PCB for giving me opportunity to give a talk on in this such an important CME. Basically, this is a unique CME about hematology, but I think now onwards, COVID will always be. Share with me.
The slide is not visible. You'll have to share the entire screen.
Okay. Yeah. So at the outset, I would like to thank IMA PCB for giving me opportunity to participate in such an important CME on hematology as a speaker. Though CME is about hematology, this is a very interesting topic about COVID-19, as everyone knows. Just now we have seen Sato sir has presented some a very good lecture about the investigations in COVID, and then he fetched so many questions. I think the questions were endless. So COVID is a topic of interest and will be topic of interest for the future to come. So I am today going to talk about the post-COVID sequelae, a multi-system disorder. So before we actually jump to the is it getting shared? Slide. When I thought about discussing the multi-system involvement in post-COVID-19, or what we call it as a long COVID-19. I decided that one must understand the disease in basics. So as everyone knows, in December 2019 from Wuhan, China, we got this deadly disease caused by novel coronavirus called as COVID-19. It soon led to worldwide spread and created a global health emergency. Classical routes of transmission were airborne droplets, surface contamination, clinical spectrum. It varied from mild asymptomatic infection to severe pulmonary failure, needing ventilation, and ultimately a multi-system involvement. Basically, it had complex pathophysiological mechanisms. Every now and then new theories are coming up, which include the activation of immune and hematological system. There is increased levels of endotoxin, tumor necrosis factor alpha, which ultimately raised the IL-6, IL-8 levels, leading to cytokine storm. Activation of coagulation cascade was also seen through endothelial and tissue factor pathways. And this was all a very complex pathophysiological mechanism behind this, a simple viral infection caused by SARS-CoV-2. Basically, the multi-system involvement in the COVID-19 can be explained by this particular mechanism. This SARS-CoV-2, it binds to ACE receptors in lung alveolar epithelial cells, nasopharyngeal mucosa, oral mucosa, endothelium, vascular smooth muscle cells in brain, gut, liver, and kidneys. And when the spike proteins of the SARS coronavirus, they get bind to the ACE receptors present in this variety of organs, then it is responsible for this multi-system involvement. So therefore, the clinical spectrum is not limited to local pneumonia, but it in fact leads to multi-order dysfunction called as MODS. Then
what is post-COVID-19? See, when some last 10 months or 1 year old, this disease is there in our clinical settings, we started getting now post-COVID patients. See, many patients, they mimic the features of current COVID disease, and we have started coming to know about something, a new entity which is called as post-COVID or a long COVID. So we are monitoring patients once they start getting first symptom for next say 2 weeks or 3 weeks, patient recovers, but then that is not the end of the story. Patients are still coming to us with multiple vague complaints, and then we started understanding about the disease itself, and this is called as post-COVID-19 or long COVID-19. So what are the commonest symptoms? So patients may come to you for vague fevers, fatigue, loss of smell and taste, it persists for a longer time, brain fog, patients coming up with difficulty in thinking, concentrating. Then there is vague headaches. Even the headaches are labeled to the constant wearing of the mask, called as mask headaches. Anxiety, depression, then respiratory symptoms like dyspnea, cough, which are anyway well known. Patients are coming with painful joints. That involves usually the joint involvement is bilaterally symmetrical, involves small as well as large joints presenting like reactive arthritis with a morning stiffness. So painful joints and muscles. Then there is post-exertional malaise, worsening of the symptoms after mental and physical activities. Also, patients are coming with the cardiac complaints like breathlessness, chest pains, angina pectoris. So multi-system involvement is seen through the symptoms also. So there are two types. One is post-acute COVID-19 and post-chronic COVID-19, or which is called as long COVID. So when the symptoms are extending beyond 3 weeks from the onset of first symptom, it is called as post-acute COVID-19. And when the symptoms, they persist beyond 12 weeks, you start calling it as a post-chronic COVID-19. Around 10% of the patients, they present with post-acute COVID-19. However, post-chronic COVID-19 is still affecting a very small proportion of the patient, considering the total number of COVID patients involved. But the total number affected by COVID infection itself is such a large that even this small proportion is now contributing major chunk in our OPDs. So one must pay attention to that chunk also. Now the question comes, why some people get skipped through this thing. They will have typical 2 weeks or 3 weeks disease and they are okay, healthy and up and about afterwards. And why some people get affected? So there is no exact etiology known, but probable possibilities are weak or absent antibody response, relapse or reinfection, then inflammatory and other immune reactions may be responsible, deconditioning, and surprisingly and most importantly, mental factors like post-traumatic stress. See, nowadays, neuropsychiatric manifestations, patients are getting anxiety, depression, and variety of psychological disorders. I think among our day-to-day routine, day-to-day OPDs, we are witnessing such patients. So that is another important etiology why explaining why some people are getting affected. Now, basically, COVID-19 is a respiratory disease. Pulmonary involvement is predominant. So when you are talking about even post-COVID-19, pulmonary manifestations, they predominate. So patients will present with consolidation, pneumonia, atelectasis, hyperperfuse areas, thromboembolic events, and ultimately patients can land into severe respiratory failure needing mechanical ventilation. So a few days ago, almost the whole world and lot of people in India were running behind the oxygen bed, ventilator bed, and ventilator has become the keyword. So this is the reason. And it is observed that in general, the lower lobes involvement is more than the upper lobes and the upper respiratory tract involvement. So HRCT, focusing not only on the pulmonary structure, but also perfusion, may help understand the pathophysiology. So you just don't have to get the mechanically about the HRCT evaluation. What about along with perfusion? So that perfusion mismatch is creating more hypoxemia. So HRCT findings may vary among patients and with time. So 3 different broad phenotypes. First is multiple focal overperfused ground glass opacities or GGOs, hyper or hypoperfused patchy ARDS-like pattern, and hypoperfused in homogeneously distributed atelectasis. From this, there were 2 phenotypes ultimately finalized. One is phenotype L, where there is impaired distribution of lung perfusion and shunting, which leads to hypoxemia. These candidates are basically for non-invasive ventilation. They get settled down with low PEEP, max up to 10 centimeters of water, and they can achieve the SpO2 of around 94, 95. Whereas phenotype H, in this phenotype, in this particular phenotype, atelectasis is preponderant. It needs moderate to high PEEP. They need prompt intubation. They need invasive ventilation and basics of chest physiotherapy, basics of post ventilation care like prone ventilation, or you give right lateral position, left lateral position, and all those things are more important in managing this second type, that is phenotype H. So it is observed that at the end of 6 months, around 30% of the cases will still have abnormal HRCTs, and 15% of the cases will show perfusion abnormalities in the form of abnormal DLCO values. Survivors of the severe illness show persistent lung damage and long-term pulmonary dysfunction. I think this is the problem that we are seeing clinically nowadays. The patients are being discharged, and it is the previous guideline was that for 72 hours, patient doesn't get fever, patient does not require oxygen, you can discharge him. But with these guidelines, so many patients, they started, stagnating in the wards because the oxygen requirement is never over. They keep requiring oxygen, and therefore the domain of domiciliary oxygen treatment has now started coming. See, we see on the WhatsApp forwards and Facebook forwards so many, like oxygen concentrator and home oxygen therapy. This is needed because the lungs don't settle only. Even after 4 weeks, even after 12 weeks, patients are still requiring oxygen, which is really a mystery to the medical field. So the survivors of the severe illness, they show persistent lung damage and long-term pulmonary dysfunction. And these problems of high and abnormal HRCTs is seen preponderantly in elderly patients compared to younger ones. So all these patients, they need meticulous follow-up. Actually, as a clinician, we need to do comprehensive assessments. We need to think that this particular patient will need a domiciliary treatment. You have to tell them about proper respiration. You have to tell them about proper breathing techniques, proper breathing exercise. Here the role of yoga, here the role of pranayam, here the role of newer and newer breathing techniques it comes, which is the biggest part of so-called respiratory rehabilitation exercises in such patients. And we must select such, anticipate such patients, teach them, and so that we can reduce the oxygen requirement and oxygen dependence in such patients. And this is all about the patients, but those who are not patients like you and me, healthy persons. So we should learn these techniques when we are healthy. And I'm sure if we increase our lung capacities, if we pay attention to our breathing techniques, if at all we contract such a disease, we'll be in a better position to fight out the battle. Appropriate management of long-term sequelae in radiological and physiological domains. I have seen very interesting videos and interesting guidelines depending on how the radiological involvement is seen, how the physiologically it has affected DLCO or the lung PFTs, and accordingly people are planning for the rehabilitation exercises, and that is really the need of time. Many times we are stuck up just by prescribing home or domiciliary oxygen treatment and oxygen concentrator, but then that is not enough. We have to go beyond that thing. But see, COVID is such an interesting thing. COVID is such a vast and large topic. I think one whole CM is not enough for the COVID. So this is beyond the scope for the today's talk. So now we move on further to the coagulation disorders. See, that is again something which was novel thing, which was a mystery when the corona came. See, that there can be thrombosis, there can be bleeding, and this was never seen and very never strongly associated with viral infection. So in post-COVID-19, there is high incidence of hemorrhagic and thromboembolic events observed. It may lead to activation of coagulation cascade due to imbalance between the platelet function and regulation mechanism of coagulation and fibrinolysis. Basically, as Dr. Satav in his talk, he has shown us there is increased markers of IL-6. So it is not only IL-6, but we don't do routinely, but IL-8, then TNF-alpha. So these levels are raised. 17% of the cases are at high risk for the venous thromboembolism, and 6% of the cases are at high risk for bleeding due to venous thromboembolism. So both hemorrhage is also a problem, or bleeding disorder is also a problem, and thrombosis also is a problem. So these DVT, pulmonary embolisms, are common. And what is frightening is, despite common use of low molecular weight heparin, see, I'm working in the Sterling. I've seen thousands of the patients for last 10 months, fortunately or unfortunately. We are using Clexane, we are using low molecular weight heparin. We are keeping watch on markers. Still the things can happen that I have taken around. And in the morning and in the afternoon on my group, I get a message that so-and-so patient, he suddenly collapsed and straight line. So there was a big thrombotic event. He might have suffered from some acute ACS. And, there are no facilities that you cannot do ECG immediately. And this thing, COVID ward, total management is different. So more or less, we are still depending on the guesswork. And so despite good use of low molecular weight heparins, we are facing this problem. Recently, when, as Dr. Sato has rightly said, the D-dimer level was 4 times, 5 times higher. So in such cases, we have even tried thrombolysis. We have used tenecteplase, Elaxim to manage the patients, and we could save few patients. So this management of coagulation disorders can go to that extent, and just simple addition of ecosprin or simple addition of rivaroxaban may not be sufficient in certain cases. Investigations of coagulation disorders, I won't go into repetition. He has already elaborated it very nicely as a routine test of coagulation. Then prothrombin time, APTT, antithrombin, D-dimer, protein C, protein S levels, and tissue pathway factor inhibitors. As we have discussed, management is with low molecular weight heparin. If there are renal issues, creatinine BUL is raised, then the patients are managed with unfractionated heparin. Antiplatelet agents do carry role in the form of clopidogrel and aspirin, but ultimate aim in managing all these patients is to reduce the risk of microthrombosis and pulmonary embolism and ultimately save the life. Next is importantly cardiovascular involvement in the post-COVID. As we have seen, the S2 receptor cells are there in the myocardium also. So myocardium gets involved. 7.2% of the cases are presenting with acute cardiac injuries. 22% of the COVID ICU cases are presenting with acute cardiac injury. I think that is a big chunk. When the patient of COVID gets admitted in the ICU, 22% of the cases can have cardiac issues. Different manifestations are myocardial ischemia, acute myocardial infarction, myocarditis, arrhythmias in the form of new onset atrial fibrillation, atrial flutter, sinus tachy and bradycardias, torsades, sudden cardiac deaths are unknown, cardiomyopathy, and patients can present with cardiogenic shock. Again, which patients are more prone? So those with comorbidities in the form of diabetes, hypertension, previous coronary artery disease, those who come up with leukocytosis. We have discussed just now about the neutrophil lymphocyte ratio. See why this is important. Something which is more than 3.6, that should be the indicator in your case. When it starts rising, see, we are seeing patients, the report comes, neutrophils around 86, 90, and lymphocytes are just around 10, 12. So you can imagine the ratio is somewhere around 7 to 8. I think Dr. Sato must have seen even higher NLR ratio patients. So that one has to pay attention to. Raise inflammatory markers. Then those who are having increased ground glass opacities in the HRCT thorax, you should be aware he can land up into cardiac issues. And more the severity, more the comorbidities, higher is the age, higher is the incidence of cardiac complications. Mechanism, as we have seen, S2 receptors are there in the myocardium cells. So direct viral invasion of the myocardium. Then basically being a predominantly respiratory pathology, patients are ultimately landing into the respiratory failure. So this respiratory failure is putting pressure on the right heart system. Patients are landing into right ventricular failure. Again, use of ventilators and use of high PEEP during mechanical ventilation is causing right heart failure. So that is another reason why cardiac problems are coming up in patients with COVID-19. Bedside ECGs, bedside 2D echoes, cardiac enzymes in the form of TROP-I, TROP-T, CPK-MB, pro-BNP, they all help to early diagnose cardiac cases. SOS, percutaneous PCI management of ACS. I don't think how much it is commonly done. Theoretically, we can say, but even at Aditya Birla, what is happening, I don't have idea, but all the cardiologists are basically asking for the RT-PCR before. If RT-PCR is negative, then only we are going for the management of invasive management of ACS. The only important thing is that, and Dr. Kalia ma'am will also agree, is that the question comes to our minds, basically all the clinicians, is that when we talk about the presence of S2 receptors and the importance of S2 receptors as a role in the development of COVID-19, whether commonest question, I think Kalia madam will also agree, whether we should continue with the S inhibitors or not, or whether we should continue with the ARBs in such patients. So I think the answer is that you should continue. There is no guideline to discontinue it. During question answer session, probably she may throw more light on this particular aspect. Then there are multiple neuro and ophthalmological manifestations also. So there is involvement of the CNS as well as peripheral nervous system, loss of smell, loss of taste, headache, seizures, GBS and Bell's palsy. See, many of us ENT people will also agree that there is definitely increased incidence of Bell's palsy nowadays. Ischemic and hemorrhagic stroke because of the disorders of coagulation, meningoencephalitis, acute necrotizing encephalopathy, conjunctivitis, and many other ophthalmic manifestations are seen. I have seen a patient of intractable epilepsy occurring secondary to this COVID infection. And literally he required all possible, whatever names you must have heard about the anti-epileptic drugs, he required so many dosages. And the young boy, then we could save him. So such things can also occur. And these are the kind of cases we have never ever seen in our clinical practice. That is the worst part. So we have to be very alert and we have to think something new while managing these patients. Again, the possible mechanisms are direct invasion of the olfactory epithelium leading directly to the brain, viral passage from systemic to cerebral circulation, followed by binding to S2 receptors in the capillary endothelium. Then COVID-19 associated coagulopathy is another reason why neuropsychiatric manifestations are coming up. There is something which is called as intracranial cytokine storm and disruption of the blood-brain barrier responsible for these manifestations. And neurological symptoms are related to the effect of systemic infection rather than direct invasion. One more system that gets affected is the hepatic and renal manifestations in post-COVID-19. So they can come up in acute, subacute, chronic forms. RFTs, LFTs are impaired. Acute kidney injuries can come up. Electrolyte disturbances, metabolic acidosis, proteinuria, hematuria, and clotting for extracorporeal circuits for RRT. These are the things. Why this happens is possible mechanisms are microembola in the hepatic and renal vessels and circulation. Drugs that are used in the management like lopinavir, ritonavir, oseltamivir, remdesivir, HCQS, all are metabolized in the liver and excreted in the kidney, so involving hepatorenal systems. Hypertension from resulting from pro-inflammatory status affects the renal peripheral vascular resistance. Angiotensin II induced hypertension can occur, and innate immune response causing endothelial dysfunction. So many possible mechanisms are there why liver and kidneys get involved. I'll just go briefly for the want of time. Endocrine manifestations are hyperglycemia, ketoacidosis, euglycemic ketosis. Not to just rush, but the hyperglycemia. See, I am managing young patients with no history of hyperglycemia whatsoever, I'm managing him on teleconsultation or video consultation. Then at the end of 2 weeks, after 17 days are over, I'm calling them such patients at my clinic. And random blood sugar is the basic thing I do. Blood pressure, manual blood pressure is the thing that I do. And 20-30% of the cases are seeing that some of the values are coming abnormal, which is very surprising. Time only will tell whether these rise in the blood sugar, these rise in the blood pressures are a temporary phenomena or phenomena to stay over there. We still don't have idea. I think this is one interesting topic, that is about mucormycosis and COVID-19 caused by the fungi Rhizopus oryzae, disfiguring, surgical debridement and adjunct antifungal treatment also cannot prevent deaths. Still the mortality rate can be more than 50%. And if the disease has progressed beyond orbit and brain, so more than, in such disseminated cases, 100% mortality rates are still there. These are the risk factors: uncontrolled DM, diabetic ketoacidosis, metabolic acidosis, corticosteroids, organ or bone marrow transplantations, severe neutropenia, trauma, burns, hematological malignancies, and so many things. See, I will focus on few things. All physicians are using, all clinicians are using zinc in the management of COVID. And surprisingly, zinc supplementation has a big question mark, whether it is causing mucormycosis. You know, there are so many things coming up in COVID-19, and you look at the official guidelines also, they are taking total 360 degrees turnaround. So really confusing the patient. So this is one more thing that is confusing. Probably zinc is responsible for increased incidence of mucormycosis. Then again, second is when there was no oxygen, no medical oxygen was available, we started using industrial oxygen. Probably use of industrial oxygen is also responsible for the increased incidence of mucormycosis. Humidifier in the ventilators is responsible, and even damp face mask. You are using the same face mask for a longer time, it may be responsible. So these are all theories. I think these are the further things, antifungal treatment and principles of treatment. But I think we should stop over here because, as I told you, COVID and post-COVID, it can be a whole CME. So I tried my best to touch all the aspects of the COVID-19 and post-COVID-19. Thank you for the patient listening. Thank you very much.
Thank you, Dr. Tondavkar. Actually, really, it was a very comprehensive and extensive, I would say, coverage of COVID-19. I understand, you are absolutely right when you said that it will take the entire day to cover the COVID manifestations and post-COVID symptoms as well. Thank you for a lovely talk. Now, we'd like to take a few questions. And before that, I think you raised a couple of queries about ACS patients and this thing. I would like to just say a few words. First of all, STEMI or acute myocardial infarction. In this COVID era, how do we treat? Being a cardiologist, I would like to say that any STEMI comes in this current era, we are preferring, even Indian, Cardiological Society of India guidelines and worldwide, we need to go for pharmaco-invasive management against the primary angioplasty. So first, we are thrombolizing these patients, whether COVID positive or COVID negative, because many of patients, there has been incidences when they have turned positive after 48 hours. So obviously they were the carriers during this time, and the logistics work against it because the entire cath lab staff is getting infected, the entire ICU staff is getting exposed to asymptomatic carrier. So in this situation, we are preferring pharmaco-invasive, that we thrombolize the patient, settle down, maybe a couple of weeks down the line. If the patient is stable, then do an angiogram and angioplasty. That is number one. Number two, however, if there is a failed lysis or patient is in cardiogenic shock, then after consider that this patient is a COVID positive patient. Even if his RT-PCR or antigen is negative, take him to the cath lab and with entire PP rituals, please do the angioplasty and save his life. That is number two. And I think number third, this thing is about ACE inhibitor. As you rightly said, there are no guidelines, whether it is European Heart Society or American Heart Society. Both of them have recommended that we should continue ACE or ARBs, that is ACE inhibitors or ARBs, as an antihypertensive treatment, even if there is overexpression of ACE1 inhibitors, because the COVID attaches to ACE2 inhibitors. I mean, ACE2 receptors. This was the initial propaganda, but right now the consensus statement says that we should continue antihypertensive therapy. Now, I think we'll take some questions, sir. One, Dr. Ajmera has asked, post-COVID blood thinner recommendation. Do you depend on D-dimer or you can give it to each and every patient post-COVID? It's a very good question. Actually.
I think this is a very good question. Most of the times, we can keep giving ecospleen if there is no absolute contraindication for that thing. I think for next, as we have seen, see, we don't know which patient will ultimately land up with long COVID or post-COVID. So better to continue ecospleen for next 4 to 8 weeks. And as Dr. Satav has rightly pointed out, if you are putting patients on rivaroxaban or dabigatran, I think then there should be a meticulous follow-up with the D-dimer. D-dimer holds the key as to how long we are going to continue with the anticoagulants in such patients. And there is no need to monitor these patients with clotting time or prothrombin time. Just D-dimer is enough to monitor these patients.
Yeah, I think just couple of things I would like to add to this anticoagulation management. Basically, I think we should divide these patients into low risk, intermediate risk, or high risk patients. Because patients who have been on home quarantine, that they fall under low risk patients. So they may not require long-term oral anticoagulation. See, there are two different things. One is antiplatelet therapy, is not anticoagulant. Anticoagulant, when we mean, it is like low molecular weight heparin, or we are talking about NOACs, or we are talking about warfarin. NOACs is basically, currently we are using apixaban and rivaroxaban for COVID-19 patients who are at high risk of developing VTE. In the hospital, either they have developed it or they are at high risk of developing post-discharge. So these are the anticoagulation therapy. If the patient is intermediate or high risk, then post-discharge, we should recommend them either low molecular weight, which becomes probably cumbersome. So currently we have got rivaroxaban 10 milligrams or apixaban 2.5 milligrams BD as a prophylactic dose. Prophylactics for venous thromboembolism, because we have seen these patients developing sudden cardiac deaths in next 2 to 3 or 4 weeks, 4 to 6 weeks. So basically 6 weeks is the frame time wherein prophylaxis is recommended. However, if these patients have developed already pulmonary embolism, which is quite a chunk of patients, basically we have seen pulmonary embolism in patients who have died. On the, there are so many studies from Spain and Wuhan also who have shown that almost 50% of the patients who died of COVID had pulmonary embolism along with the in situ thrombosis, which is a part of COVID pneumonia. So these are the patients who require upgradation of the anticoagulant therapy to 0.6 BD LMWH during the hospitalization and post-discharge. You need to give them rivaroxaban full dose, not 10 milligrams, but 20 milligrams OD as a routine VTE management and or warfarin or whatever, whichever anticoagulant, that took for 3 months.
I think
so. It depends upon low risk, intermediate risk, or high risk, and accordingly, because that is how we can save a lot of patients. As Dr. Tondawkar said in his talk, that we have seen in wards patients having sudden cardiac death. These SCDs are usually attributed to two things. One is pulmonary embolism, and second is basically ACS. Sudden, VTBF.
Maybe due to arrhythmias or maybe due to this.
And it is very commonly seen.
And many times patients are under-screened and under-investigated because of so many reasons, including cost in our case. So better to continue a safe drug like rivaroxaban for 8 weeks following COVID should not be an issue and should be a practical guideline.
Thank you, Dr. Nanda. There are many questions, but I think due to the lack of time, and we are already exceeding our time.
So IMA must take a note of this point and arrange a full CME on COVID.
I think we should have a full CME on COVID. Yes. Thank you, Dr.
Thank you. Yeah.
Okay.
Thank you, sir, for such an excellent lecture. I request Dr. Ravindra Kute, sir, to felicitate Dr. Tondawkar, sir. We are here with our last lecture webinar today. I welcome Dr. Ravindra Singh, sir, and his topic is COVID-19 recovered convalescent plasma therapy high per need. Sir is a senior consultant transfusion medicine, Aditya Birla Memorial Hospital, Pune. Sir has done his transfusion medicine from PGI MER Chandigarh. He is a fellow in transfusion science, UK. He has 17 years of vast experience with the developmental credentials and research projects, including the stem cells in regenerative medicine. Sir has many achievements to his credit, along with various publications in Indic journals. So I welcome Dr. Ravindra Singh, sir, for his lecture. Over to you, sir.
Thank you, sir. Thank you for being there. Please have lunch.
Thank you, ma'am. Good afternoon, dignitaries. And first of all, I am thankful to IMA PCB committee members to invite me for this presentation. And really, it's success itself. Really, once more than 250 attendants are there, and because of such a hot topic in entire since morning, it is covered. And I try to conclude the note with the topic which is most like in the discussion about in the news, the media, and everywhere. Share a screen. So that the recovered or conventional plasma therapy hyper need. So since beginning, once the virus is identified, so this is the basic introductions already covered. That is the coronavirus family, and it's more like a single strand RNA strain. We can affect the several members like bat, camels, mice, dog, and bird and dogs. And most coronavirus are pathogenic to human beings, but they're milder form. In the last 2 decades, there's more severe form. That is the SARS-CoV-2. That is severe acute respiratory syndrome and East Middle East respiratory syndrome. It emerges as a most pathogenic and more dangerous strain. And these strain are lead to a more propensity to send patient to the ICU. In December, that is in Wuhan city in 2019, the new strain that is detected, and that's affected entire world. And this is again that's more similar to SARS and MERS COVID infection, and more than 88% like similarity with the bat origin of the virus is identified. So now come for like the current status of the worldwide. Almost 16.6 crore people are infected with the COVID, and then 34.3 lakhs are the death reported. And in India, the scene again is not a very different one. 2.6 crore in the entire India have affected, and 2.9% were the demised. In Maharashtra, it says 55 lakhs. They have like positive with the COVID, and 85,000 plus they are the like suffered and then demised. So scene is not very good. Different treatment modality was there because it's kind of like we are in the circus. So the first day you find like different guidelines, another day you find different guidelines and keep on changing and moving in different directions. So the investigation therapy which was used in emergency was remdesivir. So different guidelines and the recommendations come for the use or not to use the conventional plasma and then tocilizumab. So I will cover only for the conventional plasma in my topic. So that is the strategic passive immunization has to be used to prevent the management of the infectious disease at least 20th century. Even for the Spanish flu, the virus, they identified and they started for the plasma therapy. So history is very long, and because the novel virus, no treatment has identified. So in those cases, so plasma that is recovered and this work as a like protective and then treatment modality for the communities. So various indications like the patient should be the RT-PCR positive as recovered as a donor, more than 18 years of age, and then the The patient the moderate to severe category, falling moderate to severe category. So like respirate rate more than 30 per minute, SpO2 switching from room air 94% less than that, and PO2 FiO2 ratio is less than 300. So these are indicated for the plasma therapy. And for the donors, they must be asymptomatic for the 10 to be donors, and post 28 days from the discharge, they have to be take for the for the plasma donors, and they must contain the antibody, the IgG antibody, specific for the spike proteins. That is the domain protein specific. And age 18 to 16 years, male donors, female, which have not been pregnant, and no history of blood transfusion in the last 1 year. Hemoglobin, that is normal, versus the other parameter like hemoglobin is 6 and more than that, is required for the selection for the donors. The question arises because a lot of questions arise because why the female donors, those are like the pregnant and multiparous, are not included for the donors for the plasma therapy. The reason behind, because they have like disparity between the mother and the child. So they have propensity to produce the antibody, that is the anti-HLA antibodies or anti-human neutrophilic antibodies. So these are high risk for the transfusion-related acute lung injuries. So that's the reason why we not take the any like the female donors; those are multiparous for the plasma donors. So this is the like once they produce the anti-HLA antibodies, anti-neutrophilic antibodies, they because the COVID patients already are compromised and they are more constitutive for the severe acute respiratory distress syndrome. Once they like try to develop the trolley, they're very difficult to survive these patients. So that's the reason female for the multiparous we have excluded from the selection criteria. So there are various proposed mechanisms for the plasma, how is to act. One is the antibody mediated, another is the non-antibodies mediated. Because the whole this contains the various the factors and the antibodies. So these factors work as anti-inflammatory cytokines, and there's a neutralizing because soluble ACE2 receptor, which is a binding site for the virus. They can neutralize the virus as well. Immunomodulatory mechanisms there. So these are the work as a soluble antigen or the products which is to be neutralize the viruses. Another one is the antibody mediated. So that is direct neutralization of the virus. So bind with the binding site and then neutralize the virus. Another is the antibody production and antibody mediated response for the presentation for the antigen presenting cells to the viruses and the killing the viruses as well. So there's different proposed mechanisms. Not the neutralizing antibodies, but other factors also work as a good factor for the plasma therapy institutions. So various dose proposed for the viruses like plasma therapy. One is like 2-dose protocol from ICMR, Indian Council of Medical Research. That's a clinical trial, and I was sent as a part of that clinical trial. So one is like 200 ml once we like give it to the patients, and after 24 hours, second dose they are like recommended. And another is the Government of India, that the DGHS, they have recommended this single dose of 200 ml, and that is the good titer because titer is most critical. If you have like high titer plasma from the donors, this is to work for the patient. Otherwise, the low titer, there is no like effect for the patients to get a benefit for that. So high titer, even a single dose is more effective even to give multiple doses. So at maximum, we can try 2 doses. Ideally, 1 dose is enough for the patient because with a high titer. So the suitability of plasma therapy, because we are not having any pinpointed like treatment modality for this virus. So how we can act fastly, because we are waiting for the vaccine since long. Even for a lot of debates of vaccines working or not working, there's a mutations has arises. So like efficacy and effectiveness already is like the in the like the mode of the discussions around the world. So those are recovered because they contain the antibodies against the specific, where the specificity is high. Because the COVID-19 recovered, the patient that of the antibodies is more specific to them. So rapidity we can produce. Those are recovered, we can select the donors, we can produce the antibodies like rich plasma, like plasma for the patient use. Ease of production, those centers they are facilitated and they are good services. They can like start like doing the more procedure and collecting the plasma. Accessibility, because expertise and good testing care centers, they have like the center transfer medicine and good facilities, they can be able to escalate better. Specificity, which I already explained to you, and immediate onset of actions. Once we give, there is immediate neutralizing effect, and then they can prevent a cytokine storm because they can neutralize the other cytokines as well. So safety, it will be safer. Is not that much of like we can say like risk here. As the risks are involved as such, we are giving the other blood component. So that will be a safer product. And scalability, production can increase when the demand is new and high side. right? So these are the factors which are in favor of the plasma therapy. So there are a lot of articles here flowing in like recent days. Some are like favoring the plasma therapy work as a silver lining. So they say because even for the vaccine is available, we are not getting 100% protection for that. So parallelly, if you are doing the plasma therapy with a good titer and the good right dose, so the patient can get a better recovery and the good outcome for the patients. So various other studies from the Journal of Mayo Clinic, again they favor the plasma therapy. Once the Karolinska Institute, they again if you're giving earlier the plasma therapy, and then the patient have a good outcome for that. So effectiveness of the plasma therapy, again from Oxford University, they says the plasma therapy should show no severe adverse effect to the patient, which already we discussed. The one dose that is more enough to the patients when giving the sufficient antibody concentration than the titer. And timing is very critical. If you're giving early, patient get a better benefit. If you're getting late, then effect will not be that much of. That's the reason the patients are in ICUs and more their severity in category, we are not getting favorable results. So the patient was mild to shifting to moderate category. At that time, we can decide the patient can be right candidate for the plasma therapy. So in that study, they have investigated the COVID-19 patient with the convalescent plasma neutralizing antibodies. In different age group, they have targeted with the different titer of the antibodies and viral titer as well. And one dose they are given to the patients, and no severe adverse events they identified. And when given to less than 14 days of the identifying the disease for the patients, they find a better result and the more good outcome for the patients. And now the questions come around we are in the India different thoughts for the plasma therapy, whether to go ahead or whether not to go ahead. And there is Dr. Ray Strahan from the founder of Vedanta Hospital. Because he says we are in the earlier the use of the plasma therapy, and then their patient get a good benefit for the plasma therapy, but they stick to the basic protocol. So early institution and the right candidate, they get a good result rather than waiting for the patient shift to the ICUs. The same way Dr. Om Srivastava, that is Just Low Hospital, they also seconded the thoughts, and he says because very early to phase out the plasma therapy, because the different people have a different thoughts, and this is the matter of debates in the worldwide. So Indian Council of Medical Research, they has straight away they refused. They says the plasma therapy is not effective for the patients, and they have given to the 239 patients involved in the patient for the target group, and from them they have given the plasma. So there are lot of debates about that, because the patient they have selected and the donors they have selected, they don't have the time the good kit for the titer the antibodies. So they have the donors they have selected almost 70% have the low titer. So that's the reason what is the anti-5, because this is the thing is the idea of the IMA trial is on the the failure side. So that's the one reason that they discuss why it is not up to the mark to the on the trial basis for the patient benefit. And those are on the ground level, they are working for the patients one-to-one, and they have seen they identified because early institutions they find a good result for that. So again, so there's debate over that. So ICMR and against the different studies and the person who are working on the ground level. So another theory is come across, that is the conventional plasma can boost the mutation for the viruses. So this again, new things have come up, and then in the news as well. They are looking for finding the reason for one of the cause for the mutation for the virus, for that is the plasma therapy. And those are the chronic infection patients and the compromise. They have a more risk for the mutation for the virus. And this is not true, because we can say this is the RNA virus, which is a quasi species. It means the mathematical model. They have to change their property to survive into the human being. So in every month, we can say 1 to 2 mutation rates have to happen in the world. So since beginning, the virus is identified until now. So more than 1,000 mutations have to identify, and this is the virus have to be when put under the pressure to survive into into the human being. So once we are giving either in the form of vaccines to the patients or in the form of the plasma, so the virus try to change their properties to escape the immune system. So that's the reason we get monoclonal antibodies that are produced by the variant vaccines, because these vaccines are targeted against a single amino acids, that is the binding site of the spike proteins, and then virus is more easier to mutate this property That's the reason the vaccine-oriented mutation more as compared to the plasma therapies given, because plasma contains the poly-specific antibodies. So even it try to cover the antibodies which are produced by the mutant strain as well. So in the first phase, if they produce the antibodies polyclonal, they try to bind the viruses which are different mutated as well, and those are escape virus, and they're escape from the even from the after the plasma therapy. They again the norm, even competent human being, the patients, they will able to generate the antibodies that against the virus. So the immunocompetent patients, they can try to identify the virus, even the mutated one, they can produce the antibodies effective on the mutant virus. So the plasma therapy, we can say, is not 100% safe that this responsible for the mutations. So mutations can happen because this is a property of the RNA viruses. So plasma therapy is dropped from the clinical medicine guideline. The recent news, then ICMR along with the AIMS, they have circulated, and so that's a lot of rebates even for the pouring of the news in the media, even for the news comes out in the news people, because they get requesting the more plasma, and even for the data they are pouring in, they says that most of the patients, they get benefited from the plasma therapy. They're rejecting the recommendation from the ICMR and the AIMS, and even for the IMA come forward for the support of the plasma therapy. They say because those are moderately ill patients, for them this work as a adjuvant therapy, because we cannot say the replacement for the whatever the treatment and the modality is given to the patient, is work as adjuvant for the patient's point of view. So you can combine it and identify the right patients. So if you're giving the better treatment for the right patients, the definitely used to help and utilizes the viruses. So take home message from my side is purely the assessment, and the treating consultant is to weigh against the benefit and the risk, and no serious side effect is observed to give the plasma therapy to the patient point of view. And one dose is enough, because we have observed most are recommended for multiple doses for over a period of time. So this is not indicated. So one thing is only to tighten plasma, one dose enough for the patient. We can able to utilize the virus for the patient. That is the only thing we can recommend. And timing is very crucial and critical. If you're giving in within 10 days, the patient definitely get a good outcome for the recovery for the point of view. And emergency use still have to be work as a adjuvant therapy for the other medical the treatment modality, and then with the taking the consideration of the patients as well for that. So we just have, because this is one part we require the consultation and agreement with the patient. They should consent it, and then we can give the plasma therapy for the patient's point of view. So 100% we can say that is phased out. This is the patient point of view, along with the current CNN current era. So it can work as a adjuvant therapy, but it cannot say that is work as a we can say the blood medicine and blood therapy kind of that. So you can try it, but it cannot dependent entirely on the plasma therapy as well. The same way, because even for the vaccination, the people get reinfected, and then they have been, most of them we can say the paternity get it severe complications. So nothing can give a 100% guarantee. Even for the vaccination, even for the plasma therapy, yes. If you're giving it the right time and the right doses, it can work along with the medical treatment for the patient point of view. So this thing had to be recommended for the patient, and our medical fraternity working with the better ground for the patient. Thank you so much. This is my all about the plasma therapy for the patient.
Thank you. Thank you, Dr. Ravindra. It was real extensive and very beautiful coverage of plasma therapy. Actually, many of the people probably did not understand the depth of your, the antigen antibodies, and which are the, antibodies are present. But still, I, being a clinician, and we have treated many patients with COVID. Finally, I would like to just obviously summarize that, as you said rightly, there is no single therapy which will cure the COVID patient.
Exactly.
There are multiple things. To begin with, vaccine. Yes, it will protect you from severe disease, but it will not prevent from getting new disease. Yes. That is number one. Number two, as you said, plasma therapy definitely has some role in critically ill patients. The only thing is, there are some people who have been giving one dose of plasma, second dose, third dose, but that is not true. And definitely, we also agree with you that one good, tighter plasma is better than two plasma. Yes. And thirdly, even there were so many questions. It's medical, this thing is so fluid. It is a relatively new disease for us. 1.5 years is not enough to learn everything about this disease. So there are going to be some caveats, there are going to be some questions, there are going to be some change in the management of this entire thing. But taken together, even remdesivir has a role, steroids have got their own role, the vaccination has got some role, and there is not a single foolproof treatment of it. We need to, depending upon every individual case, we have to prioritize that what this patient needs at this point of time. And this is what is I agree with you fully that yes, plasma therapy has still role, and IMA has also supported. All doctors would definitely say, though ICMR has taken it out from the protocol, but yes, I do agree with you. And any questions? There are not many questions in the chat box for you. Any questions there? But yes, I think all is understood or nothing is understood. So whichever way, I would think that all is understood. I will take it that way. Yeah, Dr. Sadhu has got one question. Thanks.
Actually, just I want to add, we are doing total antibody titer by taking Wilson's method for 4 liters per time. And as you have rightly said, the plasma is a good titer, actually a good outcome.
Yes.
Mainly in the adolescent age group, what we, my relatives, they are yes. And title is very important. So I just want to ask one question. What is the title of which it is taken as?
Because and our center we follow because that is the S1 receptor binding protein antibodies as RBD. And we have taken for the recommendation like 640 is the title we take for the donors for the plasma. Anything more than that is accepted as a donor. And those are below that we are refusing for the plasma donation. So that is the thing more than highest right for the patient. Yeah.
More or immunized?
Because infected person. Because the reason behind because the polyclonal antibodies they contain. So that is more effective even for like the vaccine. Exactly. So only for those on the past infection, the recovered, and that to be symptomatic. So for these don't have to be select further, and those are post vaccination we are instead of using that. We are not for the plasma donation.
One question is there, I think, patient is acute leukemia and got COVID. And what is the further? That was for Dr. Okay, we conclude the session. Thank you so much, sir, for your excellent presentation. Thank you.
For excellent presentation. I request Dr. Anu Galia madam to felicitate Dr. Ravindra Singh sir. Date sir, can you be on the dais, please? I request Date sir, our IMA president, to felicitate our chairpersons for the second session. Date sir to Maya madam. Thank you, sir. Thank you, madam. Date sir to Anu Kalia madam. Thank you, sir. Thank you, Kalia ma'am, for your valuable inputs. It's when we start working together that the real healing takes place, and it's when we all work together such event takes place. And the minds, brains, and the hands behind this need to be considered. So I request Dr. Shailaja Mane madam, organizing secretary of today's webinar, to do this honor for us and conclude the seminar. Thank you, ma'am.
Very good afternoon to all. Very important task of giving vote of thanks on behalf of organizing team of IMA PCB and today's webinar. I would like to thank today's chief guest, Honorable Dr. Ramakrishna Londe sir, for joining us online and blessing us and giving blessings to us. Thanks to Honorable Dr. Ravindra Kutte sir, Vice President IMA Maharashtra State, for joining us in person and giving his valuable inputs. Thanks are due to Ms. Rekha Dubey Madam, CEO, Aditya Birla Memorial Hospital, for providing beautiful infrastructure and technical support. I am thankful to Dr. Dilip Kamath sir, patron of IMA PCB and today's observer of MMC, for valuable guidance and support always. Thanks are due to Dr. Suhas Mate sir, IMA Honorable Past President, for his immediate past president, for his consistent support to team IMA PCB. Thanks a lot, Dr. Sanjeev Datte sir, President IMA PCB, for your kind help, support and guidance always. Thanks to all the speakers for very informative and enlightening talks. I am also thankful to Dr. Maya Bhalerao Madam, Executive Vice President IMA PCB, for time to time and valuable inputs. Thanks are due to Dr. Shubhangi Kothari Madam, Chairperson IMA PCB WTW, for constant support. I want to extend my thanks to Dr. Mandar Doifude, Young and Dynamic Secretary, for his active involvement in the arrangement of webinar. Thanks are due to Dr. Hemant Patil, Treasurer IMA PCB, for handling all the accounts of the webinar. Thanks to Dr. Vijay Sata sir, President-elect, Organizing Chairperson of Hematology webinar, for his active involvement and support. I am also thankful to my friend Dr. Archana Jadhav, who is today's MOC. I want to thank all the executive members of IMA PCB for their valuable contribution in today's webinar. Last but not the least, thank you all the delegates for your overwhelming response. More than 280 people have joined online. This is very encouraging for all of us. I will be failing in my duties. I will be failing in my duties if I don't thank team of DigiShield and Aditya Birla Memorial Hospital for their technical support for this webinar. I would like to remind and request all of you to please complete the feedback forms, because that is the rule of MMC, you all know, and you will receive it on the email, and you will receive the certificates also on the mail after that. So please complete the formalities. Thank you one and all. I conclude and declare that this webinar is over. Thank you. Thanks a lot. Thank you. Just want to remind all of you that Spandal is a e-bulletin and you will receive it on your email IDs. You please go through it and give your valuable inputs. Okay, IMA sorry, you have to download it from the IMA PCB website. I request you all to please download it and go through it and give your valuable inputs. Thank you. Thanks a lot.
All of you, please come here. We will have a good. Madam, yeah.